Okay, hi everybody. I'm gonna get started now. Thank you so much, all of you, for joining. It's so much easier to bring people to a teaching session when it's on Teams, and it's just a bit easier. In terms of planning and such with finals and all the other busyness we've all got going on, instead of having to book lots of rooms and be thinking very far ahead. So we did some teaching on endocrinology right at the start of the year. I did that with lovely Shreya from our committee. But now that we're nearing the UKMLA, I thought it would be good to do a similar session, but added in some bits and bobs. Some of it's the same, some of it's got more crossover with different specialties, for example, obstetrics. And I just thought it'd be good to record as well, because I think it was useful to people from the feedback we got. So just thought I'd do it again. First thing, I just need to get my slides up. I'm going to need somebody to unmute, please, and tell me if you can see these slides. I don't know if anyone's happy.
Yeah, we
Okay.
can see them.
Thank you so much. Yeah, so this is just how we've been teaching endocrinology currently. So we've done the face-to-face back in October, and then we did practice for finals with Oswin a couple of weeks back. And I heard people saying that endocrine was one of their hardest specialties to revise. So just thought I'd put this on again to make your lives easier. This is the UKMLA map. So I don't think this is actually the most comprehensive. I don't know about any of you, but when I go through PASS test, QuesMed, this is not an exhaustive list of everything that comes up. So I've included other things that come up quite frequently in terms of questions and trying to make sense of them, put them in a logical order so that they're at least memorable and easy to digest. So any questions along the way, I'll try and routinely, I think I can access the chat. But yeah, I think someone is still unmuted. No, we're all good. Was just hopping back to check that's all fine. So yeah, moving swiftly on. This is the summary for tonight. So instead of doing what we did last time, which was a more sort of simple overview that year 3 students could attend to, this is quite specifically targeted to year 5s. So we go into things like thyroid cancers this time. We look at malignant hypertensions, a few more A to E's. We've got the usual stuff for like routine diabetes and such as well, but it's much more emphasis on sort of broad differential lists and considering broader differentials, basically, that's more year 4, year 5 based. So those of you who came before, we always start by asking the question, what actually is the specialty that we're talking about today? So endocrinology is the branch of physiology and medicine specifically concerned with endocrine glands and hormones. We have loads of glands, of course, but the ones that are endocrine specifically secrete into the bloodstream rather than exocrine glands, which go onto the skin and epithelium via an opening or a duct. And a good example of a disorder of your exocrine glands is something like Sjogren's syndrome. That doesn't fall under the remit of endocrinology, it's much more rheumatology. And it comes in a presentation that we all know by now, dry eyes, dry mouth, and you might also get red eye as well. But we're talking about
I don't know if it's just me, but I can't hear you, Charlotte. I think.
Have I been muted this entire time?
No, it literally just happened. I don't know what happened.
Okay.
I don't know why, but yeah.
Groovy, that's odd. Well, I will try not to press any buttons again, but thank you for telling me that. I was just saying that we'll be talking more about central endocrine control today. So starting from the hypothalamus, moving down through all the different hormones of the anterior pituitary. We're including sex hormones this time, including prolactin, and then we'll move on to posterior pituitary hormones. So there's a lot of overlap with obstetrics and gynae today, but that's also quite a heavy hitting area for the MLA and generally for CCAs. So hopefully it'll be helpful, and I've got a more detailed feedback form this time so I can learn if things are actually useful or not, so that we can improve it for future. But yeah, central endocrine control. You have your hypothalamus, your pituitary, and then it reaches down to your endocrine gland. So your pituitary likes to sit within your cilia turcica, and that's why it's susceptible to causing visual field defects, which we'll talk about again later. It splits into its anterior and posterior, and then it's got these three subparts technically: pars, tuberalis, distalis, and intermedia. That's not really relevant for the UKMLA, it's just good physiology to know. But the key thing is that the anterior produces these 6 hormones versus the posterior, which only produces oxytocin and ADH. So we'll be going through each of them step by step because there's various different syndromes that can come about from each of these chemicals, and they're just good to be aware of. This is just another summary. So you start off with some kind of stimuli. Typically, this is in the form of a negative feedback loop. Neurosecretory cells then essentially create a signal that they send forward via the portal system, and then you get your production of your anterior pituitary hormones. So if we start off, we'll be moving from left to right on this screen. We'll start with TSH, downstream effects on the thyroid, ACTH, downstream effects on the adrenals, and so on and so forth. So I've tried to put little gaps in for questions as well, but thank you, whoever put their mics off before to unmute. That's really helpful because it's hard to check the chat routinely. So without further ado, the thyroid gland. We did a bit more of a basic physiological overview last time, and we always do things in MedEd in a heavy approach, which I just think is really good to get ingrained as early as possible. It means any condition you see, considering how it presents within a history, but also on examination, bedside findings, bloods, and then further formal investigations. But what we didn't cover before was thinking about the acute management of a thyroid storm and go into more depths of the different types of goiter, because something they like to do on QuesMed at least is they describe the goiter to you, and it's not just location, it's how it feels and how it feels for the patient. So I thought that would be useful to go through today. Thyroid gland, as you all know, little gland that sits within your neck, sits just below your thyroid cartilage. You shouldn't really be able to palpate it on examination. I always find myself examining too high. It's more, if you see in this diagram, it's quite useful. It's kind of just like above your clavicles, 2 heads of your clavicles at your sort of sternoclavicular joints. Sorry, just people outside the study room. So, hypopituitary thyroid axis. You start off with your hypothalamus, stimulating your pituitary to create thyroid stimulating hormone, which then stimulates the thyroid to produce T4, which is then peripherally converted into T3. There's both a short loop and a long loop of negative feedback. Short loop goes directly to the pituitary, and then you've got your long loop, which then also tells the hypothalamus. But thinking about the role of these thyroid hormones, we all are aware of the fact that being hyperthyroid can trigger a tachycardia. If you're hypothyroid, you tend to have more of a bradycardia because it's like the accelerator on a car. If you press it down too hard, things go really fast. If you take your foot off the gas, things really slow down. It's the same with digestion, diarrhea versus constipation. But some of the less discussed roles are the fact that your thyroid hormone has roles in development of your central nervous system, muscle contractions, hence you can develop things like tremors, but also your bone health. And specifically, your thyroid also produces calcitonin, which is important not only to bone health by itself, but also important downstream to the production of PTH, parathyroid hormone, which we'll talk about later, and also how quickly your kidneys filter toxic products. So those are sort of lesser known thyroid problems that become more relevant in a thyroid storm. These diagrams, I just can't get enough of them because they just really nicely visually summarize how you might expect somebody to look if they've got hyper versus hypothyroid. It's not usually this obvious, but I'm quite a visual learner, so having it in a diagram makes much more sense than a list. The important one, though, that I think is hard to drill in is the menstrual cycle changes. Now, I was really getting into this with a friend of mine the other day. We don't have exact definitive answers on which one causes amenorrhea versus menorrhagia, but on the whole, and from my teaching from endocrinology experience of questions, hyper you expect to tip you more into amenorrhea versus hypo tips you more into menorrhagia. And the where, remember that is any women on this call might be more aware. If you get into a period of quite significant stress, if you get a lot of weight loss in a short period of time, that can affect the timing of your periods. And there is feedback with this. It's to do with decreased stimulation to your pituitary, but the metabolic changes you see with hyperthyroidism, I think it kind of makes sense to lose your period because everything's in overdrive. Whereas with hypo, things are quite intense. If you get a heavier bleed, it kind of it suggests you've been more proliferative, building up your blood stores, and that's why you bleed quite a lot heavier later on when your menstrual cycle comes. So that is a possible presentation of thyroid dysfunction and one that can come up in OSCEs. So when you've got a patient presenting with heavy bleeding, you obviously start off with your screening for anemias with an FBC. You move forward to assessing their clotting, assessing for any sort of bleeding disorders, but then don't forget your TFTs because it can be an important first presentation for women. It can be the key thing they notice that they don't think is their own fault because we know so little about the uterus that usually people tend to present with gynae problems because the rest, gaining weight things, dry skin, they might keep trying to intervene with. Whereas with the menstrual cycle, people tend to come forward. Generalization is just my experience so far. So in terms of describing pathology, we went over this months ago, but for anybody new, it's so much easier to see it in a diagram form. So we talked about things going from the hypothalamus to pituitary to the thyroid. When you discuss pathology, you go backwards. So an issue with the thyroid itself is primary. Issue with the first stimulus to the thyroid, the pituitary, is secondary. Issue way further up with the hypothalamus is tertiary. Much less likely to see that in isolation as a thyroid presentation, but it is possible. So we'll be talking through primary hyper and hypothyroid, as well as mixed presentations that tend to start as one and go towards the other. We'll also touch upon a few extra bits and bobs in terms of the secondaries that we didn't quite touch on last time. So starting with Graves' disease. Graves' disease is the top cause of primary hypothyroidism, and 90% of the time it's due to antibodies which mimic TSH. They essentially bind to the TSH receptor and stimulate the thyroid inappropriately because it thinks it's being told what to do by the pituitary. It's actually some rogue antibody that's appeared on the scene and decided to take over the shop. However, note, 3/4 of the time, you've also got an anti-TPO antibody grumbling in the background. That'll be more important later and we'll talk about why, but it's just good to think about, particularly when we come to our thyroiditis later. But TSH receptor antibodies are usually the top one. So, signs specific to Graves. I had animated this slide, but because it's there, we might as well just talk through it. We talked about thyroid acropathy before. Pretibial myxedema, so changes on the front of your calves and movement of your orbit forward, so you get exophthalmos proptosis, seen best if you look from the top. So if you bring the patient's head slightly back, you can see protrusion of the eyeball forward beyond the line of the eyelids. So the descriptions you tend to get in UKMLA questions, the acropathy will be described as swelling and clubbing. The myxedema, characteristic orange peel skin. And then in terms of the eyes, they'll be red and bulging with retraction of the eyelids. But I thought it was a good opportunity. There's so many other causes of clubbing, one of which is sarcoidosis. And sarcoidosis can also cause pretibial skin changes, specifically erythema nodosum. And later on, we will talk about the fact that sarcoidosis is infiltrative as well and can cause thyroid manifestations. So it's not completely absurd to consider getting a chest X-ray and maybe getting a serum angiotensin converting enzyme level because sarcoidosis can also manifest in a similar way. Same problem with IBD, although it's much less similar in terms of the pretibial changes. It's more of a sort of round, deep ulcer. But this is why it's a good idea to learn the difference. These are the three main presentations that you get on the front of the shins, because you get your sort of like inverse champagne bottle and stuff, but that's more generally the lower legs. Pretibial myxedema is your orange peel. Erythema nodosum is round little tender nodules. Pyoderma gangrenosum, gangrenous, I always think ulcers. And that's a nice way to distinguish between your sarcoid IBD and thyroid, because they can be nasty. And sarcoidosis can manifest with thyroid changes. And if you've got a background of autoimmune disease, you're more prone to thyroid changes. So I've seen it done. And I just thought, why not help out other people who may get caught out in similar questions? And then we'll talk more about thyroid eye disease, but you need to have things like an orbital cellulitis in your differentials because both are acute pathologies and both need urgent escalation to secondary care for various interventions. But orbital cellulitis, you're thinking more IVs. Graves, you're thinking more urgent decompression. But you also get proptosis if you've got an issue with the cavernous sinus just behind your eyes, and it kind of pulsates instead. So if you hear proptosis, it's not necessarily thyroid eye disease. And this is just really highlighting the importance of a good history. So with your Graves, making sure that you're checking all of those hyperthyroid symptoms. Hopefully that's okay for everyone. I'm just going to hover and check for any questions. Okay, seems like we're fine. Groovy. So thyroid eye disease, not always Graves, usually Graves. So this is just a nice picture of the orbital sinus. I thought it particularly shows the nice comfy fat around the orbit quite nicely. So the theory of why you get Graves is that you get lymphocyte infiltration into the sort of periorbital space, and this triggers a localized inflammatory response. This causes your eye to bulge forwards, and naturally when your eye is beyond the eyelid, you get, first of all, you get the lid lag because the eyelid can't stretch around, but it's also going to feel really irritated and gritty. So look in questions for gritty sensation of the eyes, and on examination they may have obvious chemosis. So you can think about your other sort of pathologies causing gritty irritation and your keratitis and things like that, but it'll be specifically associated with a proptosis. So that's one to think about, because otherwise orbital cellulitis, you don't tend to get the gritty sensation. Nice way to rule it out, and it won't be pulsatile, so it won't be the fistula. You'll also get the pain on eye movements. So you also get painful eye movements with something like a scleritis, because it's basically where your extraocular muscles insert is really inflamed and upset. So it just means your eyes, they're in a lot of pain anytime they try and contract any of those muscle areas. But the big one to worry about is you can end up compressing your optic nerve, and that's when you get actual visual involvement, because the eyeball can just continue to protrude forward, feel a bit gritty without actually affecting your vision. But when you get compression, that's when you need to start thinking of, oh God, I need to escalate this to eye care today, instead of just doing those more sort of low-level thyroid interventions. You also pair this with IV steroids to calm down the inflammation. And you need to do this early, because if you catch thyroid eye disease too late, it's gone fibrotic. So you've stopped getting that ongoing inflammatory process and it's begun scarring. So you can't really do any steroids, that it's not going to respond to medical therapy anymore. You can only go for surgery, and even then it's typically irreversible. So you need to move quickly if you think there's any eye problems. Relieve any symptoms with eye drops and ointments, of course, but make them quit smoking. So don't quit smoking. All of this is not really going to make any difference. Smoking is the big one when it comes to thyroid eye disease. And don't give them any radioactive iodine. That's usually the definitive management of hyperthyroid, which we'll cover in a sec. But do not do it in thyroid eye disease. It makes the whole situation worse, because you're giving a radioactive substance which loves to trigger immune responses in a very vulnerable area, and it will make the eye disease worse. So, primary hypothyroidism, typically Graves, can also be nodular. So you tend to get adenomas. You can get a single one on its own, or you can get multiple nodules. So you investigate with an ultrasound scan because you're going to be able to palpate the thyroid and it'll feel quite nodular, one of our differentials of a goiter. But an ultrasound is the best way to see, is that one I'm feeling or is that two? And they're just quite close together. And just in general, I feel like I see adenomas everywhere. Like it's always pituitary adenomas or thyroid adenomas or so-and-so adenoma. And it basically just means it's a tumor of glandular tissue. So we're talking about endocrinology today, endocrine glands. When you get a tumor of glandular tissue, it can produce hormones. And that also helps explain any other sort of adeno things that might come up later on. So I just found that helpful for me. These teaching sessions are useful for me, revising as well, and just making sense of medical life. But yeah, that's primary hypothyroidism. And in terms of the treatment, first thing you need to do is confirm it's hyperthyroidism and not a transient hyper going into hypo, which we'll talk about in a second. So you need to get your TFTs done. You're basically going to have the thyroid acting out by itself. It's being told, dude, chill out, quiet down, but either because you've got someone faking the role of TSH and making it act out, or it's got this new nodule, this adenoma, producing T3 and T4, irrespective of the rules. So you're going to get high T3 and T4 regardless of what your TSH is. So this is a presentation of primary hypothyroidism on your TFTs. And you can either inhibit TPO or inhibit TPO and the peripheral conversion of T4 to T3, which is the more active hormone. And that's with carbimazole or propylthiouracil. And then, of course, you can give radioactive iodine, but I just harped on do not do that if they've got eye disease. And you need to recheck levels of carbimazole after a month or two. Key thing is, though, you can only use propylthiouracil if your patient is pregnant. I've got a summary of the different thyroid manifestations in pregnancy later, but propylthiouracil is the safer one to go for. Doesn't have any teratogenic evidence. And then you can also just take the thyroid out if things aren't working. All right, so in that regard, we've got a patient who's come in with an emergency presentation of hyperthyroidism. So first question, how do people think they would present? If you just want to put it in the chat because I can see it now. I've got a really hyper-energetic thyroid. Yes, radioactive iodine. So you know how when you have, if you think about your amiodarones, iodine, although you want to convert your iodide to iodine to make thyroid hormone, it's also toxic to the thyroid. So if you use radioactive iodine as well, it has a toxic effect rather than a physiological beneficial effect. And I think it's something to do with how it's uptaken in the production pathway of thyroid hormone, if that makes sense. Yeah, exactly. Tachycardia, hypothermia, tremors. Yeah, brilliant. GI issues, all the stuff that no one wants. So usually we do our heavy approach, but when it comes to an emergency, everything stops and we go to an A to E approach. So always, fifth years will know this by now because we've got our OSCEs in a few weeks, but anyone in fourth or third year, you need to always go back and check your intervention. The reason you do the A to E, I did a practice one today, and the doctor said it's for when you're exhausted, you've been on call for days, and you have to be at that bedside and do a sequence of systemic evaluations that take you to the point of the patient being safe. He said the less thinking you can do when you practice your A to E's, the better, because just imagine your brain's switched off. So airway and breathing can kill you first. If you're still doddering about checking their abdomen soft, non-tender, but they've lost their airway, you're no longer safe. So just keep going back. If you intervene, check. Has that worked? Are they still maintaining their airway? Are their SATs coming up? Is the wheeze relieving? Etc., etc. So in a thyroid storm, as you guys said, you tend to get the sort of fever and tachycardia and everything. But if they've got no treatment of their thyroid and they've just got this swelling in their neck, we know NHS patients are neglectful. Do they have compression of their airway? That is entirely possible. albeit unlikely, but some people do leave it quite late. So check they've actually got a viable airway. Then we go on to the heart rate. They'll be quite profoundly tachycardic. So you'll get an ECG. We'll think about what that might show, but unless you can say absolutely hand on heart that this isn't a possible ACS, consider getting your TROPS when you get your dual access. ECG, AF loves to poke its head out through the thyroid. We'll talk about why in a second, but if you want to have a think about why that might be. And then, of course, your fever. Initiate your sepsis 6 early. They're going to have quite profound hypothermia. Temperature is the way that your body likes to root out infection, though. So if you've got a really raging temperature, think sepsis until proven otherwise. A thyroid storm can be critical, but we know sepsis definitely can be critical, and an ischemic heart can definitely be critical, so just be safe. And then, of course, keep an eye on their BP. Do they need fluid resuscitation? Keep an eye on their GCS. Remember, the thyroid's important for your CNS development, so it can alter your mental state, make you profoundly confused. And then, if they're really sweating, could this be a pheochromocytoma, especially if they've got a really whacked up blood pressure when we talk about pheochromocytoma later? Could we need alpha blockers? And then, of course, check for the tremors. So propylthiouracil is actually the preferred first line. You give it through an NG tube, and then you give the iodine, like I was just explaining for the question in the chat, has a toxic effect on the thyroid, makes everything calm down, stops you getting as much thyroid hormone out, and then you can also double down on that with hydrocortisone. Calms everything down, also stops peripheral conversion of the hormone. So just tries to bring things to a level where you can do more definitive management. And then you need to think about where on earth, because I've seen a lot of thyroid stuff in the community. My GP placement, it was like every day I had at least 2. But why on earth are they having a thyroid storm? Are they ill? Have they had some kind of trauma that can include surgery? Have we given them radioactive iodine treatment and it's made their thyroid, instead of calm down, kick off? It's trying to perform a coup. It's had enough of the system, so it's storming. It's excuse me. Is it just their first presentation? We don't know. Okie dokes. So thinking cardiac, AF, if you've explained AF to patients, I personally tend to think about it in the terms of everything in the heart likes to be nicely synchronized with one another. Everything's perfectly aligned. One wall's thicker, one wall's thinner, so that ultimately they're squeezing together to produce outflow that's compatible with adequate tissue perfusion. If your heart is constantly being told to just drive all the time, eventually that integral electrical system is going to short circuit. But also the atria themselves are just going to turn around and stick 2 fingers up and say, look, I'm not working with you anymore, and go into this irregular, unsynchronized rhythm. So you get AF quite a lot with hypothyroidism, and you can also end up with high output cardiac failure because they're just overworked. So cardiac and hypothyroid go hand in hand. So again, screen for your ACS, get your ECGs. Consider, do I treat this AF acutely? If they've not got signs of hemodynamic instability, you can consider treating the underlying physiological cause because you've got a clear trigger, and then move forward with reviewing the ECG. Or if they do, might consider your vagal maneuvers and your beta blockers, rate, rhythm control, all the rest. Okie dokes. So, just checking for any questions. Ooh, someone in the chat. We love people in the chat. Oh, it was a thing for earlier. Yes, Brill. All right, role of thyroid hormones. Again, just considering your bone health. You can get your osteopenia and your osteoporosis with your hypothyroid as well. So just think about, particularly in older people, if they might need a DEXA or a FRAX calculation. But yeah, just double checked for any questions. It seems like everyone's fine, but just to give an opportunity if anyone does have any. Let me know if I'm going too fast, too slow, saying too many words, not enough words. I'm just going to sip my coffee because apparently I'm choking on an almond croissant. Okay, groovy. Seems everyone is happy. So just thinking about some secondary causes of hypothyroidism, bit of a hint there in terms of what one of the causes might be. But you can essentially get the pituitary, as we were talking about before, an adenoma. You just get functional TSH production because it's a glandular tissue, and you can get compression of the optic chiasm, which causes a bitemporal hemianopia. You can also get, though, that the thyroid just becomes resistant to thyroxine. The pituitary even becomes resistant, so that negative feedback fails. It's no longer being told to switch off, and it just continues stimulating the thyroid. And the thyroid, being the obedient little organ it is, will continue making thyroxine, and the pituitary is just never listening and stopping. So it's resistant, so it just keeps on going. And then you've got your more fancy ones. And these are all related to your gonads. So beta HCG can actually activate your TSH receptors. So not dissimilar from a Graves presentation, you can end up with a gestational presentation of hyperthyroidism. And we also think that women who get hyperemesis gravidarum, that tends to be due to high levels of beta HCG. So particularly ladies who get like a teratoma or something, which is where you get your molar pregnancy much larger than you would expect for dates in terms of their fundal height, and lots of beta HCG. They get lots of vomiting as well, and that's possibly a sign that they might be more susceptible to thyroid problems. So there's at-risk groups you can screen for the thyroid. Not routinely checked, but if ladies start presenting with possible sort of hyperthyroid type presentations, you might consider doing a TFT. And then there's a very rare form of a teratoma, which is basically just ectopic thyroid tissue. So instead of it being, you get those teratomas that are like someone's teeth and their hair, you get, it's called struma ovarii, where it's literally just all thyroid tissue just hanging out by the ovaries, which is just the coolest thing ever because the body's super cool, but also why, when it comes to like MLA questions, like why do I know this now? But it's all part of the fun of studying this degree. All right, I've sort of hinted at mixed presentations a lot, and you get these transient tricksters where they make you think you're hyperthyroid and then they tip back over into hypothyroid by the next time you do their bloods. Drug-induced likes to do this. So iodine is the funky one where we said before with radioactive iodine, you can kick off and get a hyperthyroid. And that's almost like its last dying wish before it goes into hypothyroid. So amiodarone can do a similar thing. And then you get your dequervains with your sort of illness type fevery picture. Postpartum, you can have had all of this beta HCG floating about, and then it just goes, and you tip into hypothyroid because it's used to being told what to do loads by this new visitor, and then they leave, and they don't know what to do, and you get postpartum thyroiditis, which starts as a bit hyper and then goes hypo. And then, of course, you've got your Hashimoto's. Tricky, tricky Hashimoto's. But this is a nice little summary, I thought. Well, it's, pat on my own back. Just pregnancy and the thyroid. So you get gestational, again, the beta HCG, give them propylthiouracil, and then you get your hypo. So it's it's the beta HCG, but also, how in COVID, pregnant ladies are one of the at-risk groups. And whenever you read in pediatrics a kid with a funky fever and a virus, they say, do not go near anyone pregnant, as if that's like the beeline a child makes whenever they're ill. It's because they're basically immunosuppressed. Everything they can do is focused on building that baby. So their immune system is just like, give the baby antibodies, don't worry about me, give it to the baby. So when they come out of that state, their body's like, ooh, thyroid, no way. And it starts attacking it, which is very rude. But again, the body being quite cool. Hypo. So we talked about anti-TPO. You can get it in Graves, but it's more common in Hashimoto's. So TPO helps in conversion of iodide to iodine. Get rid of that. You just got too much iodide, which is useless. TPO is also important for integrating that iodine into the, not prodrug, metabolite. I know the word I mean, before you make a thyroid hormone. So if you lose it again, you're not going to get your thyroid hormones, and Hashimoto's loves to destroy that enzyme. So confusing that you get it often concomitantly with TSH antibodies in Graves, but Hashimoto's, who knows? But this is the key one that you tend to get lots on. I say QuesMed because I don't use PassMed. I'm not sponsored, but I just don't use PassMed. So maybe they say lots on PassMed too. But yeah, QuesMed loves it. And then there's your other causes. So you can mess about with scalpels and radioactive substances. You can have bad luck in childhood where you just don't have a normally developed thyroid, or your thyroxine. The whole process just isn't working. And then the big one is sarcoidosis. I love and hate sarcoidosis. It's so cool. Like, you hear things about like neurosarcoidosis, but when I get it in a question, I just really hope I can definitely rule out the other four, because I'm like, right, sue me, it could be sarcoid. I don't know. So again, here is sarcoid rearing its beautiful yet rather ugly head. And hemochromatosis as well. We'll talk about hemochromatosis with the pancreas as well. It's one of those where iron loves to deposit itself where it's not welcome, and then it messes things up for that target organ. Does anyone know what this sign is? Ooh, question. Of course, Lily, I will go back to the thyroiditis. If someone wants to have a think about what sign that is. So this was the thyroiditis, Lily. So you get your drugs. They basically, whenever you do something toxic to highly glandular tissue, it likes to go inflamed first and overact. And then when the toxic effects kick in, all those cells kind of like either die off or shut down. And then you get your subacute one where you get your de Quervains, which is usually someone's not very well. And then you get your postpartums after immunosuppressed, and then you come back to normal, and Hashimoto's that we just talked about, which hopefully that was okay. Yes, Anastasia, you're so right, Queen. It is Queen Anne's, but it's also called Hertog, which is just a loss of the outer third of the eyebrow, which is kind of in keeping with that hypothyroid picture where your hair goes all sort of dry and straight as well. So yeah, this is just a nice summary of interpretation of TFTs. So I think giving that logical work through of the hypopit thyroid axis is the most help I can give on this, because if T3 and T4 are high, genuinely just try and think, is this a solo agent or is it being told to act inappropriately? So if it looks like it's solo, that means it's primary. If TSH is still high, that means the thyroid's doing its best and TSH is responsible. If it's low, TSH is high, it's still trying to stimulate it. So again, that's the thyroid being a solo ranger. And if it's low and TSH is low, that means they've both given up trying. The funky one is subclinical. This comes up a lot in the PSA and counseling. If someone has a derangement on their TFTs, so like subclinical is if they might have a high TSH and their thyroid hormone's normal, or they might have a low TSH and their thyroid hormone's normal. If they're not symptomatic, just present your patient with the options and say, you're fine. You might not be fine, but we can just check that again in a few months. And can you keep an eye on these symptoms? Or do you want to do something? So it's very patient-led, because if they're fine, why put them on a drug that might make them not? So it's just about repeating their TFTs in a few months' time. Okie dokes. Just in case anyone's new here, Hazowski's coming up. You've got someone with a neck lump. Let's assume I've not been told this is an endocrine station. I've just been told, like they did a few years ago, person's presented with a neck lump. Please do a history and exam. What are you going to do? Okay, so this is just an opportunity to think about how you might take your history. So Socrates is great. Always ask where it is, when it started, does it move when they swallow, does it feel like it's pulsing? And this is just a nice summary list for you. So particularly look for that red flag of any associated lymphadenopathy. If it's rubbery, lymphoma, until proven otherwise. The rest are much less sinister. And then I added in this list as well because I thought it would be useful to people to think about what causes a smooth versus a nodular goiter. So you've got your nodules, your multinodules, adenomas and things that tend to present as more little discrete masses, and your thyroid cancer. So thyroid cancer loves to come up. First question on thyroid cancer, what are the different types, and can you order them from most to least common? The lump list again, of course, Anastasia, I will also send you the slides. But meanwhile, if anyone wants to say about thyroid cancers, that's your neck lump list, Anastasia. Anyone in chat? Yeah, papillary, medullary. Yeah, the one that older women get, amazing. Yeah, so top one, like you all said, papillary, 60% of cases are papillary. But then you also get your folliculars. Medullary is actually the one that they like to put in questions though, because like someone rightly said, it comes up with multiple endocrine neoplasia. And then you get the anaplastic. Medullary is the one that you test for with calcitonin. The unloved child of the thyroid. We always think about T3 and 4. What about my guy calcitonin? Anaplastic grows very quickly and is very invasive. So that's thyroid cancers, just a lovely question that always tends to come up. Okay, and you guys rightly said that it's associated with MEN, but opportunities for revision, which MEN and what are the other ones? Thought I'd be nasty. I know I'm a horrible person, but I figured it's better that I'm mean instead of the UKMLA. Just trying to soothe myself. Okay. Pancreatic and adrenals are MEN2. All right, all right. Okay, we've got some disagreement in the chat. Pituitary 1, yeah, yeah. Okay, so the way I like to remember this is if they've got anything with their pituitary, that's the top. Like that's the first in the list because it controls everything downstream. Like that's the first guy that's going to control everything else. Medullary thyroid, I don't know, I don't remember it honestly. It takes 2 words to say because you can't just call it a medullary cancer. Medullary thyroid, it takes 2 words. Works for me because that also applies to mucosal neuromas. But that's then A and B. I've honestly just had to learn it. And to make life easier so you don't just have to learn the tumour, they'll tell you the presentation. This tends to be how they all show up. So look for someone who's got 3 Ps, 2 Ps, and the other one. Yes, that's a good way, Lily. I like that. But then I forget the Ps. Exactly. It's like pituitary pancreatic pheochromocytoma. So if they've got galactorrhea, raised calcium, and just ulcers everywhere, you have to wonder what's going on. So I tend to think of the galactoria that's pointing me towards the pituitary, and that's my number one. He controls everything else. So downstream effects. If they've got a hoarse voice, I don't know, guys. I fear we can come up with some kind of nifty mnemonic on this, but I figured a nifty set of slides would be all right for now. And then 2B, they just love to be Marfanoid in appearance. Who knows? Anywho, if anyone comes up with a nice mnemonic for multiple endocrine neoplasia, be my guest. So welcome in this chat. But yeah, that's the thyroid gland. So this was our kind of checklist plan, and we've gone through everything. So is there any questions on the thyroid? Anything people want me to go back over?
Sorry, could you go back over the slide with the men 1 and 2?
Oh yeah, of course. So if people are getting loads of funky tumors, there's a possibility that they might have a like familial inheritance. So you've got 3 subtypes, 1, 2A, and 2B. 1 is your pituitary, is your parathyroids, but also you get a gastrinoma. When you've got loads of gastrin, you're also susceptible to more ulcers, and you tend to get them in weird and wacky locations instead of your nice peptic ones in your duodenum and in your main gastric antrum. And then 2A, you get medullary thyroid cancer, so raised calcitonin, parathyroid tumors, and pheochromocytomas. We'll cover those later. And then 2B, you get mucosal neuromas, and they tend to have a Marfanoid appearance. So they have like the tall, slim guy with the long fingers and the raised palate.
Can I just check if it's hyperparathyroidism that you get with
Yeah,
both of them?
I think it's supposed to be a parathyroid like adenoma quite type thing.
Okay.
So you get high calcium typically because your PTH stimulates calcium and phosphate release from your bones.
Okay.
That's
Thank
my
you.
understanding. I may be wrong, in which case endocrinologists come for me, you know what I mean? Okie dokie. So in terms of UKMLA map, these are all the presentations that can fall under the thyroid that we've now touched upon. And this is all of the different parts in terms of conditions that we've now touched upon. So it may have seemed like I talked for a long time, but we have now hopefully covered quite a few bits of the MLA map. And if anyone gets tired and they need to tap out, that's fine. A big reason for me doing this session was to get it recorded and then upload it to YouTube. So if anyone needs to drop out at any point because they're exhausted, it's a very tiring time, do not hesitate. I was going to give you guys a little break now. I'm just conscious of time. So I will come back at 55 instead of 58 and just give you all a chance to breathe, digest the thyroid information, and then we'll come back. But don't hesitate if you're exhausted to come back later. It's honestly no problem. I will take no offense and you can watch it back later. It's no problem. So yeah, 55, I'll be back. But let's just take a pause, a breather, and then we'll do the rest. Alrighty, Mooney. Little 2-minute brain rest, doom scroll, whatever you got to do. I, for one, am a tired little birdie recently. Okay, why is my screen going funky though? Either way, I'm back on my slides. So hopefully everyone can still hear me okay, because we've now ticked off TSH in our list, so we'll move on to ACTH. These are the two big hard hitters. My idea was if people need to go, they'll do the big ones, which is the thyroid and the adrenals. Both can come up in Manchester exams, and they're useful for the MLA as well. So if you miss the rest, just tune back in, watch it as the recording. No offense taken, just here to revise for myself and help you guys. So whatever you need. Anyway, adrenal glands. I love using these little characters because they make some of the most irritating topics seem cute. So the adrenal glands sit on top of both of your kidneys. They're made up of your vascularized medulla in the middle, and then they're surrounded by 3 layers of cortex. So this is a nice diagram. Then we've got the same rationale as we did before in terms of the axis. Hypothalamus gives those nerve impulses, those neurosecretory nerves, and then you get your pituitary responding, producing ACTH, which works down on the adrenals and all the hormones that they make. Describe it in terms of primary, secondary, and tertiary pathology again, but they tend to come under different specific names, mostly blokes' names, who found a problem, gave it his name, and now we must all remember the various people's names that come up in endocrinology, because everybody loved hormones, apparently. Structure of the adrenal glands, disgusting description, but deeper you go, the sweeter it gets. I didn't make it, but annoyingly, it's what works. So you start off with your glomerulosa and your mineralocorticoids, then your fasciculata and your glucocorticoids, reticularis produces androgens, and then your medulla produces peptides and catecholamines. It's a neurosecretory area. So we'll go into each of these and what presentations they come up with, how we might approach those, and differential diagnoses. All right, so zone by zone, I made this diagram for the last one, and I am proud of her. So she's back to visit us again. It's an abstract representation of the adrenal glands, their different layers, and the hormones that are produced. So starting off with aldosterone, heavy hitter. It's the end product of the RAA system, renin, angiotensin, aldosterone, which we all know through the regulation of blood pressure. Aldosterone has dual activities, so we know that it increases sodium reabsorption because where sodium goes, water follows, but it also, by its mechanism of action, causes upregulation of ROMK channels. So that's also in the kidneys and increases the amount of potassium that is lost in your urine. So that's why you get hypernatremia, but might also be a dilutional hyponatremia, depends how much you're retaining, and a hypokalemia. So it specifically acts also on the alpha intercalated cells that excretes protons into the urine. So you get some exchange of sodium and protons, aka H+ ions. So this is just a nice summary of the pathway. You can see how a dehydration, when you're dehydrated, you're going to end up with a decrease in your blood volume, which affects your pressure, and then you've got your very careful juxtaglomerular apparatus, which are then going to cause the renin, produces angiotensin. ACE works to do your angiotensin 2 production, which is why we can use ACE inhibitors to help with blood pressure as well. Then it responds by acting on your adrenal cortex. Aldosterone then increases sodium and water reabsorption because the two like to come together, bolsters your blood volume, restores that blood pressure. So another way that you can get that effect on the adrenal cortex is also if you've got too much potassium because of that effect of aldosterone. It causes increased excretion of your potassium. That's important because I got a question quizzing you on it later. All right, so the one that likes to rear its ugly head in short, simple best answers, single best answer questions is Conn syndrome. So just as we were talking about earlier, it's another adenoma. So it's a tumor of glandular tissue that can produce aldosterone. You can also get your bilateral hyperplasias, carcinomas, familial raised levels of aldosterone, but Conn syndrome is by far the most common one. So how's it going to present in terms of a heavy approach? On your history, you're increasing your reabsorption of sodium and water with your aldosterone. So you're going to end up with a lot of headaches. Whenever someone's got like too much fluid or too much pressure being bolstered, it likes to present with a nasty headache. And in terms of your blood pressure, your RAS system likes to keep things in a careful balance. And just like we had with the thyroid before, where it's not listening to your pituitary, now your adrenals aren't listening to your pituitary, but they're not listening to the downstream. Well, it's the kidneys this time instead of the pituitary, really. So your renin and your angiotensin are chilled. They're saying, my dude, blood pressure is fine. And aldosterone's just gunning for it, continuing to bolster that blood pressure, retain that sodium, that water, and that's causing treatment-resistant hypertension. So you can spot this by basically checking, a bit like we did with TFTs, we wanted to compare TSH and T4. This time you want to say, okay, is aldosterone being told to do this by someone? So you look at the renin ratio. So if you've got a relatively normal to low renin, you can pretty safely say aldosterone is acting by itself. We've got an adenoma somewhere, someone's making aldosterone that's not meant to be. And you then also get your hypokalemia, like we talked about, because of it's SGK1 that aldosterone acts on, and that's ENaC for sodium and ROMK for potassium. And you're going to get metabolic alkalosis because you're shunting out loads of H+, your protons, in exchange for keeping this sodium. So it's going to be a lot of loss of acid, which makes you alkalotic. And you're also continuing to lose that potassium. So you'll get a metabolic alkalosis with low potassium. If you wanted to investigate this further, adenomas are tumours, so CTs can pick them up. And if you wanted to distinguish, don't know why in particular, between a Conn syndrome and a bilateral adrenal hyperplasia, I don't know if maybe you get an abnormal CT finding that prompts this. You can do some venous sampling and try and look for subtle differences between the two. Unlikely question, but a possibility. And just a reason to rule something out. If you are pretty certain from the presentation it's cons, and they say, how would you investigate? Don't do adrenal venous sampling. Okie dokie. Why will it not click? There we go. Okay, so because I'm rude, I gave you guys a spoiler on what this question was, but I've added in nasty calcium. And thank you to somebody on this call who taught me about why this is. But I just thought it would be a good question to give people a go at because they love talking about side effects of heart failure meds. So give it a go, homies. Okay, so while people think about this, Lily, I always think of it as similar to like why in diabetics you get polyuria. So in diabetics, you've got your sodium glucose transporter in your kidneys, and this is the one that's supposed to sort of pump out your sodium and glucose together. And when you've got loads of glucose circulating around, your body is still desperately trying to remove it. Like, even though you've got a problem where you're still continuing to have far too much glucose, your kidneys are still working overtime trying to get it out. So we inhibit the SGLT2s later on as one way to calm down the hyperglycemia in a type 2 diabetic. But like a type 1 diabetic, their kidneys are still trying their hardest to get that glucose out and increase the amount you put in your urine. I think similar happens with Conn syndrome. So your aldosterone is causing ENaC insertion. So you're taking up more sodium from your tubular fluid. But that's also got a dilutional effect because where sodium goes, water follows. So when you've got this really high pressure, that disrupts your gradients and your loop of Henle, I'm pretty sure. So you still end up peeing out more than usual because you're holding on to so much sodium, therefore you're holding on to so much water. Dilutional effect, feedback to your sort of glomerulus and your detection systems means you then pee out more. Makes no sense. Renal is so counterintuitive, which is why I was meant to teach renal next week, but we've now got an F1 who's going to come in and teach it. That hopefully will make sense of this absolute mess that is figuring out the kidneys. But yeah. Okay, yeah. Anastasia's put it in much more formal tones, but exactly. Aldosterone escape. You're holding on to sodium, water's following, body tries to protect itself, and that's through ADH. Less ADH, so less anti-diuresis, so more diuresis, more peeing to fix. I love your emoji reactions, they make my day, and thank you, Anastasia, that's so helpful. Okay, fab. So, answer to this one is B. So, spironolactone is an aldosterone antagonist. It belongs to the potassium-sparing diuretics, and it can be used as one of your heart failure meds. So it causes hyponatremia because aldosterone causes you to take back up your sodium. So you're going to lose more in your urine when you block aldosterone because your ENaCs aren't there. Your ROM-K is also not going to work as much to shunt out your potassium, so you're going to hold in more potassium. And the way that calcium and magnesium are reabsorbed is by the establishment of like these positive voltage gradients. So it basically pulls in more positive charges when you've got these circulating in the serum. They like to cross, they're not directly across the membrane. They're sort of in these interepithelial spaces. There was a nice diagram I saw. But you'll get hypercalcemia and also probably hypermagnesemia, which is an interesting one. I didn't know before I discussed it with a friend on this very call. So yeah, I thought it was a good question to chuck in. So this is just another explanation. I've talked about SGK1 before, but just in case anyone forgets and doesn't want to go through the whole video, this is just the explanation of why that happens. Okay, so we've done cons, now Cushing's. Cushing's syndrome, different than Cushing's disease, is an excess of cortisol, your stress hormone in the body. Your stress response is essential to self-preservation and protection. You've got corticotrophin releasing hormone, stimulates pituitary to produce ACTH, then you get your cortisol, and it's really important to your body clock and your circadian rhythms and responses to illness and other external stresses. So when we think about Cushing's syndrome, I like to align excess of cortisol with physiological role of cortisol. So cortisol causes stimulation of gastric acid secretion. So you're going to get GI distress. Cortisol causes a reduction in calcium absorption from your intestines. So if you've got loads of cortisol, you're going to get even less resorption of calcium, which is essential for bone health. So you're going to get osteoporotic changes. And then you've also got the increased susceptibility to infection because cortisol and the stress response are key to mitigating your body's response to infection. So hopefully that makes sense. And all of this in terms of the Cushing's presentation, again, I think is nicely displayed with this diagram, but I always just think of they've got moon face, they tend to have distended abdomen, and they get those striae over the abdomen as well. And their skin is quite thin, their extremities are quite thin, because they're in this like overstressed state, but without external stresses. So the usual sort of rest and digest, like your skin systems and stuff, they're all just kind of like, what is going on here? And they go really thin and they stop functioning as they should. Okie dokies. So that's Cushing's. Try and keep an open mind to it. Again, a lot of these you're going to see similar patterns of a raised blood pressure and a glucose derangement. We'll talk about secondary diabetes later, but these are your classic ones to look for. Cushing's disease, yet another adenoma. Cushing's syndrome is where you get this excess of cortisol, and it can also be a paraneoplastic syndrome Cushing's disease is a pituitary adenoma, so you need an MRI brain. You can also do your CT taps for your small cell lung cancers and your paraneoplastic syndromes. I'd meant to put in a nice slide later on about all your different causes of hypercalcemia of malignancy. I'll pop that in later, but just want to think about. It's like inherently female related. I like to remember it because you know how post-menopause you get all these bone problems. You also get it with, I'm pretty sure it's ovarian, breast and endometrial cancers cause hypercalcemia, and then a non-Hodgkin's lymphoma. But that's just a point for later. I'll chuck in the slide at some point. I've made an Anki on it, so it'll just be a copy-paste jobby. All right, so with your cortisol, you basically want to do, all of these are about proving the ability to suppress it. It's basically, you've got all the clues to suggest that someone is acting out, making too much of a hormone. You just need to prove whose fault it is. With the thyroid, we do TFTs because we can quite sensitively detect TSH and thyroid hormone. When we were just talking before about Con syndrome, you look at renin, who's supposed to control aldosterone and do the ratio with aldosterone. Now with Cushing's, we want to basically prove if our usual way that we shut off cortisol still works. So we can do an overnight dexamethasone suppression test because you're meant to have high levels of cortisol in the morning because it's waking you up. So dexamethasone should be able to suppress cortisol because it's this glucose feedback with your corticoid release. So you start with a low dose, and then if that's not suppressing your cortisol, you try a bit of a higher dose because maybe this person is just less responsive to dexamethasone. So you start off cautious, and then if that's not quite giving you the response you want, then you give your high dose of dexamethasone. So you should have suppression. If you don't get decreased levels of cortisol, then someone's acting out. Just as before, we had low TSH, T4 still producing. It's because the thyroid is producing excessive amounts of hormone. Same thing with before with aldosterone. The renin is saying, dude, chill out, and the adrenals, your zona glomerulosa, is still saying, no, I'm going to keep producing aldosterone. Same with Cushing's. It's being told, stop making cortisol with dexamethasone, and it's continuing to make it. So, low dose, high dose, Bob's your uncle. Any questions on that so far? Nope. Nice silent chat. Okay, so just a summary. We've done too much aldosterone, too much cortisol. So it makes sense to now look at a condition that's defined by too little of both of those. So just giving us that nice diagram again, hypothalamus, pituitary, adrenal glands, primary, secondary, tertiary. Primary, Addison's disease. My goodness me, to Manchester love an Addisonian crisis. So we will be covering an Addisonian crisis. And then, of course, your secondaries we can think of later. Big one is, though, like a pituitary apoplexy, a Sheehan's, which is where you get like big PPH after childbirth and it affects your pituitary, like a protective shutdown mechanism. And then lots of suppression of your hypothalamus through steroids if you're massive is another cause of insufficiency. But by far in the UK, adrenal insufficiency is mostly caused by Addison's. You can get it from TB, but that tends to be in parts of the world where TB is more endemic. For example, it's still quite prevalent in South and Southeast Asia. TB rates are still, I think, one of the highest there in the world. So that'll still be a leading cause of adrenal insufficiency there. So just think about your demographics. We know that question banks love to stereotype. So if they've come back from somewhere and they've got adrenal insufficiency, they're probably hinting that it's not Addison's in this person. But that's just the way my mind works now. I've been doing questions for too long. But anyway, adrenal insufficiency, Addison's affects all the layers. But the main two that become symptomatic, if you've got low estrogen, low testosterone, that's more of like a grumbling complaint. Low epinephrine, low norepinephrine, again, kind of grumbly. It's your aldosterone and your cortisol being low that mess things up. Hence, I've put these just after we've covered aldosterone and cortisol. So, think about the opposite of before. Aldosterone's there to boost your blood pressure. You've got no aldosterone, you can't boost your blood pressure. Aldosterone boosts your blood pressure through holding on to sodium. You've got no aldosterone, you can't hold on to sodium. Aldosterone boosts how much potassium you get rid of. You can't get rid of your potassium, you've got more potassium in your blood. Aldosterone holds on to sodium by getting rid of protons. So now we're keeping them all. We're losing the sodium, so we're keeping the protons. They have to give and take. So I get a metabolic acidosis with low sodium and high potassium. I'm going to be craving salt. I'm going to be dizzy as heck because, like we were saying before, when blood pressure's high, I get a headache. When my blood pressure's low, I'm standing up and I'm woozy and I'm tired. Acidosis, I'm going to feel rotten. I've got acid flowing through my veins, so I'm probably going to vomit a fair bit. So that's your insufficiencies. So having a think about the autoantibodies tends to be anti-21 hydroxylase in case that comes up in a question, and it's just a nice way to distinguish if it is true primary adrenal insufficiency, so if it is true Addison's. Again, we talked about your aldosterone. Now think about your cortisol. It's your stress hormone. We talked about dexamethasone, about your glucose feedback. In cortisol, a really key thing is that it's got this nice counterbalance system with insulin. So you want, in stress situations, to have plenty of glucose available to you because you're working in overtime, you're fight or flighting, you're trying to get away from something. So you want free glucose to facilitate the actions of your cells. You lose cortisol, you lose that stress response, that balance with insulin, and you end up disoriented, confused, and weak. That's why if someone comes in newly confused or with new sort of CNS changes, we do a glucose. You can also get issues with feedback to the pituitary. So if you get too much of your ACTH precursor, it's going to cause you to have this weird feedback loop. So look for kind of skin darkening, especially at their skin exposed areas, because melanin is essential to sort of UV protection and sun responses in the skin. So insufficiencies in your aldosterone and your cortisol really throw you off in quite funky ways that manifest in your nice adrenal insufficiency way, with your sort of skin darkenings, your weight loss, your salty cravings, your dizziness. You just feel run down and terrible. So let's say I'm suspicious of adrenal insufficiency. You can use the ACTH stimulation test. So it's literally the same rationale as all of the ones from before. I think my adrenals aren't making stuff anymore. Let me try and poke the bear and see if it will wake up. Ideal world, we'll have a short synaptin available. So you're going to have a look for how your plasma cortisol is just hanging out on its own. Then give some ACTH and see if it boosts. If it doesn't, you're thinking Addison's. However, if you're in a GP surgery, that's probably not available to you. So you're just going to assess how high their cortisol levels are in the morning. That's when they should be their highest, so the most detectable. If it's above 100, if it's above 500, good news, nice job. Probably not Addison's. Below 100, definitely start thinking insufficiency. Somewhere between the two, great. Now I've got to refer them to secondary care and they will not be seen for a long while. You've got to do an ACTH stimulation test. So this is just another fancy bit of info. It's not always insufficiency. Just have broad differentials like, are they malnourished? Could there be other reasons? And this is just another diagram. You guys know I'll always come through with a diagram. So it's just everything we were saying, that everything gets thrown out of whack, but it's just a prettier way of showing it. So you just need to replace what they're lacking in. Endogenously, you produce your own aldosterone, cortisol, etc. So replace it. But remember, when you're sick, the patient needs to know that they need to now do the role that their adrenals used to do when they're sick and replace the stress hormone. So they need to double the level of hydrocortisone they take. Aldosterone has no role in the stress response, so they shouldn't be doubling their fludrocortisone because it doesn't usually double. Why would you double it now? So they need to be educated and they need to be given a steroid card. In case of any emergency situations, people need to know to give them their steroid. And I saw a really great case in ED of a lady who had profound adrenal insufficiency and had really careful dosing to make sure her hydrocortisone requirements were met. And her GP had sat and written a 2-page long document that detailed all of her previous admissions, what worked, what hadn't worked, and it was just brilliant. And she kept it with her, and she was super informed of her condition and could advocate for herself, which makes all the difference in these situations because we could get the right things prescribed very quickly, and then she was stabilized pretty pronto. So it's just a really helpful thing to do, to take that time to educate patients. All right, Addisonian crisis. It's OSCE day. You've thought it's going to be an upper GI bleed. You've thought it's going to be an asthma, a cheeky NSTEMI, and Manchester, their biggest love affair is with an Addisonian crisis. So they've given you an Addisonian crisis in your A to E station. It's a life-threatening absence of steroid hormones. They're nauseous, they're vomiting, their tummy hurts, they're confused, they don't know who they are, where they are. I highly doubt they'll give us someone in a coma. It's A to E time. So they'll probably be profoundly hypovolemic. Their volume's gone. They're going to be at risk of cardiac arrest and at risk of stroke because as soon as you disrupt any kind of flow through the blood vessels, any changes to turbulent flow, you risk both of these events. Hypoglycemia, especially kiddos. Kiddos love to tank their glucose, and it's a really common way Addison's might present, and their GCS will be gone, like we were saying before, and the exact electrolyte derangements we expected. So going through the A to E, less likely to have an airway compromise. It starts more at circulation. So when you get that dual access, be asking for electrolytes, use and ease, looking for those signs of hyponatremia, hyperkalemia. If they're hypovolemic, are they going into a pre-renal AKI? Look for their urea, their creatinine. Keep having a look around, constantly considering if you've got the right differential. However, if you think it could be Addison's, give them hydrocortisone. It's life-threatening to not have that hormone. It's life-threatening if they're in a stress situation, if they're shocked, hypovolemic, they need hydrocortisone because usually their body would be spiking cortisol to help you with all of this. But if they're not having those upstream responses, like the aldosterone is not responding to any kind of like vasopressor type intervention, it's not going to suddenly step in and start bumping up blood pressure. You need to act early and give them their hydrocortisone. So you start off with 100 milligrams. If you've not got access because their veins are terrible because they're hypovolemic, just give it IM, and then you can start doing a slower transfusion, and then you can think about adding on that fludrocortisone, the aldosterone later on. Start off with your stress hormone, get that out of the way first, and then we can start worrying. And obviously fluid resuscitate them. Like I said, aldosterone's not going to magic its way in and start doing something. You need to give them fluid resus yourself. And be careful. We talked about sodium and glucose exchange. Thank you for putting in the chat, guys, about the aldosterone escape mechanism. But when you're correcting sodium, be cautious of how that might tip, not correcting sodium. When you're correcting glucose, be aware how that might tip over to your sodium levels because that can exacerbate the problem further of your depletions. Okay, so a Manchester favourite cleared. Chat, chat, chat. How are the friends doing? So I think, Anna, you're right. Like most of the questions I think we get, Addison's presentations are quite benign and they come up in GP and they start off with a 9 a.m. cortisol and then move to the ACTH. But the primary thing you're looking for is to prove Addison's. If you want to definitively prove Addison's, you need to prove that your adrenal glands are eroded, they're wasted away to the point they don't respond to ACTH. If you've got low cortisol, that's not definitely Addison's, if that makes sense. You can have like a pituitary problem. That means you're not making ACTH. We'll come to it later when we talk about like cranial versus nephrogenic diabetes insipidus. Like, it's different mechanisms of how you prove that downstream is the problem, not upstream. So ideally, you can do the short synacthin first, but if all you've got is cortisol, it's a good like warning shot to then proceed to doing the synacthin. That's been my understanding.
No, I agree with that. I
okay.
was just thinking, you know, let's say your GP and they say, what's your first line management? Obviously, gold standard, I'm going to do like a short synacthin. But I was wondering if it's actually like first line.
Yeah, definitely. I think from the guidelines I've seen, it depends what you've got access to. But I'll have a look and review it and I'll send it to you, or I'll put it in the chat of this call. So that's a good question. Correcting the hypoglycemia. So correct the hypoglycemia, but it's just be cautious of it. Because, you know, when someone's hypoglycemic, it's like, can they swallow? Okay, can I give them a couple tablets? Do I need to give them some IM glucagon, or do I go straight to IV glucose? I'm pretty sure you still go to IV glucose. It's just about keeping an eye on their electrolytes, because you're giving them saline. Good, it's got sodium in it. But then if, on the other hand, you're correcting their glucose quite rapidly, your SGLT2 receptors are going to start kicking in. So you'll start kicking out sodium again. So it's just about, don't think it's all fixed in your A2E. It still needs to be quite careful and gentle so that things don't downtrend again and you don't get a crashing blood pressure again. I think in the terms of the OSCE A2E, it'll be more of a stabilize them acutely, get them life-saving steroids, fluid resuscitate, correct the abnormalities, and then we worry about the pedantics later. This is more of a like general comment on the hypoglycemia, but I'm pretty sure it's still IV 10% glucose. Okay. Awesome. So yeah, you do 9 a.m. cortisol. If they're quite stable. It looks like NICE is saying if they've got no urgent treatment indicated, you do the 9 a.m. cortisol and then you go to ACTH. So that makes sense. Brill. Thank you so much for sending in the NICE guidelines, Lily. Anyway, that's the Addisonian crisis. And then another adrenal crisis that can happen is Waterhouse-Friderichsen syndrome. It tends to be post-mortem and it moves really rapidly. So if you have somebody come in and they're saying, what might you see on their post-mortem? I've had questions like that on QuestMed before. Just have a think. But Waterhouse-Friderichsen syndrome, Neisseria likes to do it, and so does strep pneumoniae. You get a petechial rash, then it becomes purpuric, and then they go straight into septic shock. It moves very quickly. It's a very niche little thing that I thought I'd just chuck in whilst we're talking about life-threatening insufficiencies of the adrenal glands. You literally just get rupture because of a severe infection, because you get disseminated intravascular coagulation, and it basically just makes your adrenals go. So yeah, hope that makes sense. Finishing up your zones, thinking about androgens, but only the adrenal ones. It's much more mild than the gonads that we'll talk about in a second. It's more about your libido. So if you get insufficiencies, you tend to get someone with low libido. And it tends to be seen more in women than men, because the gonads in men, the testes, produce large amounts of testosterone that masks the underlying changes to the androgen levels. So if you think about congenital adrenal hyperplasia, that's one where you might see changes to your levels of androgens. And I'm pretty sure you see like a precocious puberty. But I will just confirm that because that's just off the top of my head. But this is one to think about in the interim, is hirsutism, because it's actually the testosterone you get from your adrenals that can underpin hirsutism. So in women, they get the sort of like decreased libido, they get that abnormal hair changes. Men tend to be more fine. So just thinking about when you get hirsutism, who should you be worrying about? What are we thinking of? It's a favourite in gynae. Not to give any hints. Yeah, PCOS, and what's the criteria called? Yeah, Rotterdam criteria. So this is just again a lovely gynae one. So for your PCOS, you need to have either your clinical or your biochemical criteria. I think you can just have 2 clinical criteria as well. So you need to look for that oligomenorrhea, less likely than amenorrhea. I don't know why I keep changing how I say that word. It's like Benedict Cumberbatch saying penguins. Just keep changing it with every iteration. Evidence of cysts on the ovaries, and then proof of excess androgen, which comes typically in the form of having hirsutism and differing patterns of hair growth due to the raised levels of testosterone. So, final layer of the adrenals, you've got your medulla. So it's mostly postganglionic neurons, and it's a lot of your sort of metabolic adrenaline, noradrenaline type innervation, your sympathetic, your fight or flight. So you've got your somatostatin and substance P that are more about your sort of growth and your pain, sleep, mood regulation, whereas epinephrine and norepinephrine are all of your like panic. So if you're fight or flighting, that really helps explain why pheochromocytoma happens, because it's a rare neuroendocrine tumor of these postganglionic neurons where you literally, it's like you're just panicked for no reason. Your blood pressure's up. You've got a crazy headache because of that pulsing blood pressure and too much fluid. You've got palpitations. Your heart's like, oh my God. You're chicken licking, thinking the sky's going to fall down. You're anxious and you're sweating. So literally, it's been the same with everything. Just prove you've got too much of your metanephrines. Just look for free metanephrines. That usually proves your pheochromocytoma. You can then start having fancy look-sees with imaging and whatever, but just find your metanephrines. It's been the same pattern with everything we've discussed so far. High thyroid, low thyroid, high aldosterone, low aldosterone. Like it's always proving I have too much, I have too little. Bloods are your best friend in these investigations. And then if you've got too much of something, block it. Just as we were using carbimazole and propylthiouracil for the thyroid, pheochromocytoma, block it with alpha blockers. You can think about beta blockade later, but your sympathetic nervous system is alpha 1, alpha 2, beta 1, beta 2 receptors, which I got asked when I was in anesthetic theatres, and it had just left my noodle. But now that I remember it, it makes much more sense why we can use alpha and beta blockade for pheochromocytoma. Who knew there were so many connections between the body's physiology? Oh, wait. However, that's pheochromocytoma. So it can present as another emergency. You can have your hypertensive urgency or hypertensive emergency. The hypertensive emergency is the one where you've got signs of end organ damage. Top candidate is check your kidney function and check for papilledema. If you've got a BP greater than 180 over 120, you need to basically create a controlled drop. If you're suspicious of any kind of malignant hypertension, this isn't just pheochromocytoma. You start off with your dihydropyridines. So your dis is your nifedipines, your amlodipines, and you bring that blood pressure down to about 160 over 110 within 24 hours. Just take it step by step. Let the body recover. Remember, you've been in panic mode because you've been told to be in fight or flight, and now you can chill out. So if we think it's a pheochromocytoma, we've got lots of free metanephrines, you go for IV alpha blockade, and then you can think about beta blockers later. Just like we were saying with general pheochromocytoma, start with alpha, follow with beta. Lovely Greek alphabet. Then if you're thinking more of like end organ damage of like an encephalopathy, if you're thinking, oh my gosh, I've got an aortic dissection, if it's a pregnant lady with a preeclampsia and she's might even have an eclamptic seizure, bring that pressure down with IV labetalol. It's a really great IV beta blocker. With the encephalopathy though and the dissection, you can also use IV sodium nitroprusside. And of course with the eclampsia, you use your magnesium. I once got asked the question, how much magnesium can you safely give a person? And they said, think about eclampsia, what do you do? And I was like, just give magnesium. And he was like, exactly, just keep giving it, it's fine. So who knew? Especially if you've got concerns over potassium and potassium removal. Remember, your ROMKs are entirely magnesium dependent, so there is no point replacing your potassium if your magnesium's not replaced. If someone's got low magnesium, it does not do any harm to give them some magnesium first, because all of your other measures aren't going to work if you can't get the potassium out because the channel won't open. So remember, with your aldosterone, you hold on to sodium via ENaCs. Get rid of potassium via ROMKs. If you're trying to get rid of your potassium, you need magnesium. If you don't have enough magnesium, good luck. You're just going to have to hand punch the potassium out of there. So yeah. Another horrible question I got asked this year, because apparently the consultants are finding me with these niche questions that I don't know when they ask me. But anyway, another opportunity for some inherited disorders. So we talked about MEN2 earlier, specifically this is 2A. You get pheochromocytoma with your 2A. The neuroma is your 2B, less likely to get your pheochromocytoma with it. But I also got a question on von Hippel-Lindau syndrome, where they also had a renal cancer, and I was trying to scratch my head and think about, oh gosh, which MEN is that? And it wasn't. And then I had, I'm pretty sure, was it a kid with a neurofibroma and a pheochromocytoma, and I got that wrong as well. So basically anything I've got wrong, I'm trying to put in this presentation. Yeah, so neurofibromatosis type 1, they have these like cafe au lait spots, so coffee with milk. That's like the colour of the spots. And if they have neurofibromatosis 2, they get the vestibular schwannomas, which is much more like an ENT presentation. They're bilateral and you'll have some cranial nerve involvement, so think of like a sudden sensory neural hearing loss, a tinnitus, something like that. But yeah, just more inherited disorders that like to come up in the MLA. A nice little slide for you so you don't have to click through QuesMed. Alrighty, so I like to do a spaced repetition to make sure that the stuff I've taught has been retained, and if it hasn't, this is an opportunity to be like, oh, that's a bit I didn't pick up on before. So, oligomenorrhea, it's a possible way that someone could present. What does everybody think of this question? Okay, hopefully people have had a think. Ah, someone in the chat, yay! We love someone in the chat. Okay, I love this because it's healing for me because you're all putting the answers I put. So, having a closer look at the TFTs, remember the whole thing we want to do is prove, is the thyroid performing a coup and going out on its own, or is there a dark horse telling it to do it? And the key thing in this, yes, we've got high T4, high T3, but the TSH is high. So the TSH itself being high suggests that this is a pituitary problem. If we test A, anti-TPO, that's either a Hashimoto's or a Graves'. If we do serum calcitonin, we're again just proving in a different manner if we've got a hyperthyroid. We're possibly looking for a medullary thyroid cancer because of those C cells. If we do an anti-TSH, we're looking, like you guys rightly said, for a proof of Graves'. But the presence of an anti-TSH receptor antibody wouldn't explain why the TSH itself is staying raised, because the feedback, there should be negative feedback to the pituitary telling it to shut up, and it's not working. And an radioisotope scan is also not going to help us distinguish what the problem is here, because it's looking at the thyroid itself. The thing you need to do is look at the pituitary. Now, I put that question in because, again, I got it wrong. And I thought it was a good one to go back over and see the ways that they subtly sneak these in. Because I think, for me anyway, I always think the thyroid's the nice one. But it's not, actually. It's low-key kind of rude. So, yeah, answer was MRI pituitary. And then I've been banging on about the MENs. So, which one has pheochromocytoma? And brownie points if you can name the other associated tumours, just so we can really drill these in, and then you guys don't even need to do an Anki, because I'll wind you up with it. Dee, dee, dee. Yeah, 2A. Glorious. Yes, it's 2A, and then you've got parathyroid tumours as well, and medullary thyroid cancer. MEN1 is your pituitary adenoma. So that's going to give you like a galactoria, because it's usually a prolactinoma. It's going to be a parathyroid problem. And then what's the third one? Oh, pancreatic gastrinoma. So you're going to get funky ulcers. And then 2B is your neuromas and your Marfan's. So yeah, 2A. And then I put 3 in just to be a trickster, because, pranks, funny. We all loved that. Okay, someone's in the chat. Yeah, I was just being a meanie. I just thought putting in MEN3 because I'm such a prankster. But anyway, last one. Which antibodies are seen in both hyper and hypothyroid autoimmune diseases, just to really drill that point in as well. Yeah, anti-TPO. So 75% of Graves would be positive for anti-TPO, but it's most commonly prevalent in Hashimoto's. Yeah. So it limits the conversion of iodide to iodine in the thyroid, and that's key for synthesis of thyroid hormones downstream. All right, so I didn't put a tick in this box for malignant hypertension because I didn't finish that slide until about 10 minutes before I was teaching this class. So it is now ticked. Everyone watching, yay, ticked malignant hypertension. So UKMLA map-wise, we've also cleared out a fair ton of those as well. So if I were to have been smart and put on the other presentations that we've knocked off and the conditions, we've done the majority of endocrinology so far. I've now gone into pretty much everything else. Again, if anyone needs to drop out, please just do the feedback form. I'm going to continue teaching because it's beneficial for me, but it's a tiring time. If you need to drop out, no offense taken. You can come back, watch the recording, get the info when you're more awake and ready to receive it. No problemos. So, we've done the TSH, we've done the ACTH. Any questions in the chat of anything, anyone that needs to drop out, anything they need reiterating? I am so sneaky. Okay, glorious, because we're going to move on through the anteriors. We'll take a little break, then we'll do oxytocin, ADH, and then the pancreatics. It's not too long on these next ones, it's just high hitters that come up in lots of questions. So, hyperpit gonads axis, yet another glorious axis. This tends to come up far less as a primary, secondary, tertiary than it does a PEDS presentation or a later life presentation of gonadal insufficiency. So it tends to be described as hyper or hypogonadotrophic, and it's malfunctioning of the gonads essentially, because usually FSH stimulates spermatogenesis and testosterone, which are two things key for male fertility, and in women the production of the follicle and the corpus luteum, key to their menstrual cycle and for fertility for them as well. So common presentation is typically around infertility. So a couple who's usually been trying, I think the cutoff is 1 year, maybe 2 years, correct me if I'm wrong, guys, struggling to conceive. Someone's got hypo or hypergonadotrophic hypogonadism. And then the other one tends to be menstrual irregularities. So it's, again, the whole thing is, has the gonads, have they shut down of their own accord, or are they not being told to work anymore because they don't function autonomously? They need to be told. So I've just summarized the disorders here. Big ones are ovarian failure. So you look for if it's premature in young ladies, if they're over a certain age of like average age of menopause, you think if this could be menopausal. So then you've also got your Klinefelter syndrome. So you need to karyotype these patients. Again, it tends to come later in life because they tend to be healthy throughout their whole childhood. They've got those normal gonadotropes. They'll have the background androgen levels that you get from your adrenal glands with your ACTH. So they may have some gynecomastia. They will probably have quite small testes, but otherwise their development is normal. They'll be quite tall, and it's basically a key differential for anyone who's got primary hypogonadism. So the pituitary is still trying to talk with the testes, but because they've got this additional X chromosome, it's interfering with their testicular development. So if somebody was having a more secondary hypogonadism, so again, we can use the primary secondary terminology, but I've not seen it like that in questions. If the pituitary is not telling the testes to do their thing anymore, that might be a Kallman's syndrome, and I like to think of it as call gone, because they've not got the call out to the testes / all of the stimulation is gone. So it's just a nice, easy way for me to remember it. And it's all secondary. So think about like pituitary problems, prolactinoma. So you're going to get that kind of mixed picture. If they're more gynecomastia, think, have they got an extra X chromosome? Whereas if they've got more of a galactoria and nipple discharge, have they got like a prolactinoma? So yeah, different things. And then especially like with your steroid uses and things, could that be another cause of why their pituitary is not telling their gonads what to do as well? You'll notice those are quite male predominant presentations. So just ones to think about that rear their ugly heads in the endocrinology section that feel like they should fall more under pediatrics. So that's FSH and LH. That's what I'm going to do in here because the rest is more menstrual cycle. So either it's going to be community menopause care and HRT, or it's going to be gynecology and your PCOS and things like that. I don't think that falls under the remit of full endocrine. It overlaps, but I think that would put us way over time. So then moving on to your growth hormone. I put this under bits and bobs when we originally did it, but unfortunately UKMLA wise, it's a big one. Growth hormone does what it says on the tin. It makes you grow. So you end up way too tall, your stuff isn't fitting, your jaw's growing, your tongue is growing, and the space between your teeth is growing too, because as your jaw expands, it's going to take your teeth with you. Don't know if you've seen those creepy x-rays of babies when they've got all their adult teeth, but your teeth are kind of like set up when you're born. That's why you can like put a photo of me next to my nanny and we've got the same change in our tooth. And it's kind of like, oh, nanny, how cute. But you can't really control much of what happens to your teeth, hence kids get braces because there's very little we can do to change things. On the other hand, it's taking up space where there's not a lot. So if they've got like a space occupying lesion, sort of raised intracranial pressure type headache, so worse with straining, worse with bending forward, things like that, query who's taking up the space. And if they've got those other things, if they're growing a bit funky, think, could it be an acromegaly? So where and why? It's literally, you need to think about who is causing me to have this excess growth hormone. It's literally, all of endocrinology is just like, I don't know if you guys played like Professor Layton growing up on the DS, or if you like a sort of mystery problem solving type thing, that's endocrinology. And I think it's fascinating in that way because you're constantly searching for who's responsible for this syndrome, which tissue is overacting and causing this problem. So you've got a source of excess growth hormone, but there's actually a secondary mediator that tends to be responsible for that. So more than 99% of patients, it'll be due to insulin-like growth factor 1. So we'll talk later about the feedback between glucose and growth hormone. But basically, you get too much of IGF-1, and this means that all of these other pathways you've got going on that you're seeing how they converge onto your IGF-1, they all come together too because of this growth hormone. So the downstream effects that we actually see in acromegaly are the IGF-1's fault rather than the growth hormone itself, if that makes sense. If growth hormone were to keep on just doing its thing, it would present rather differently, but it's because of the fact growth hormone stimulates the liver and IGF-1 that we get so much overgrowth and so much metabolic dysfunction. So you can see the different causes. It's a lot of tumors. So on the left-hand side, it's the pituitary adenoma again. Pituitary tumor is one of the conditions of the UKMLA, and it can literally, if you've not noticed, it can be producing TSH, it can produce ACTH, it can produce FSH and LH, it can produce GH, and in a bit we'll see that it usually produces prolactin. Any of the anterior hormones the pituitary adenoma can make, just depends where those cells get excited. On the other hand, you might just have an ectopic production of the growth hormone. Tends to be more of like a neuroendocrine tumor, or medullary thyroid carcinoma can do it too because the medullary cells are a bit funky. They do your calcitonins, they do your growth hormone. Small cell lung cancer, I believe that technically falls under the umbrella of a neuroendocrine tumor as well, and then your pheochromocytoma. Any of those sort of like neurosecretory type tumors, they might give you an acromegaly type picture. So moving along, please let me move along, computer. This was just a little Venn diagram I made. You can get acromegaly, but you can also get something called gigantism, and it's quite distinct because one happens when you're a child, one happens when you're an adult. So it's this abnormal growth, but in gigantism, you think more if they've got a gonadal issue as well, if they'll get a delayed puberty. And they're quite distinct conditions. Both can come from a pituitary adenoma, or like we were talking about before with the neurofibromatosis type 1, the cafe au lait spots and stuff. You can also get the neurofibromatosis type 2, and you can either get neuroendocrine tumors in gigantism. So it's just, if it's in a child, go more towards gigantism. If it's in an adult, think more of acromegaly. And then this is just some characteristic facial features. So if you think of all your different facial bones, I always think about the ones you can palpate in a baby. If they're all growing weird, it's going to cause like my forehead to come forward. It's going to cause my jaw to come out. And then if you think about all these different bones that make up your face, I think your growth plates are mostly in your frontal bones because you think about babies' weird little heads, and then your jaw as well. So they can all start moving forward under the influence of growth hormone. So yeah, these are all the different changes you can see. Just something to look back over later on. Just going to check for any questions because I like to yap. Yap, yap, yap. Ooh. 1 year to start looking if something's wrong. Oh my God, yeah, Himish, don't get me started. MEN4, I just noticed that as well. And I thought to myself, oh golly gosh, why on earth is that happening? And Teams is trying to tell me that my meeting ends soon. And I don't know if that means that the meeting will shut off. So let me just fiddle around with something. I'm just going to change the timing and make it go for longer so that it won't kick me out. It's not going to go on this long, guys, I promise. It's just so that it doesn't stop and like kill the recording. Okay, where was I? Let me go back to slideshow mode. Okay, this is just another nifty diagram on growth hormone physiology that you guys can have a look at later on. And this is a summary of acromegaly. So, as we were talking about before, think of their history first, what they might come in presenting with. It'll be sort of like cosmetic type changes possibly, but they may also come in with a headache. And if you've got a space occupying lesion headache, it's going to be about ruling out those key red flags. Examine them bedside, have a look at the back of their eyes, particularly do their visual fields, their perimetry, because they might have bitemporal hemianopia, and bloods, get the IGF. It feels most logical to look for growth hormone in a growth hormone excess, but remember it's the IGF-1 that is actually causing the primary mediation of the changes. And then glucose. You should, if you've got plenty of glucose in your bloodstream, have a response back to your pituitary saying, well, no more growth hormone, please. So if you do an oral glucose tolerance test and you still have loads of growth hormone, you think, gosh, could this be acromegaly? And again, our favorite friend, an MRI pituitary. You can CT tap if you're groovy, but mostly it's an MRI pituitary. Screen for the other hormones, because if you've got an adenoma that's affecting one group of cells, you can't definitely say that it's not going to include the other anterior pituitary hormones. And there's a risk of colorectal cancer that comes with acromegaly, so keep an eye on that, because it's going to cause the excess proliferation in the colonic cells, so it can cause a possible cancer there. But management-wise, you can chop it out. You can either inhibit the release with somatostatin, which blocks growth hormone. You can block the receptor where growth hormone acts and stop the liver upregulating all the IGF-1. Or cool thing, dopamine inhibits growth hormone. So if I've got lots of dopamine acting, I'm going to stop producing growth hormone. And we'll talk about this in a minute when we talk about antipsychotic meds. When you think about the metabolic side effects, the release of growth hormone from the anterior pituitary, the prolactin you get in your body is also the anterior pituitary. So when you're blocking dopamine, you're blocking the blockage of those hormones. So that's why you get raised prolactin with your antipsychotics, because you're blocking dopamine. Okie dokes. On that note, prolactin, it's lactotroph cells in your anterior pituitary. They act by themselves and they make milk. So they make the milk first of all, they maintain the milk, and then they help you to continue to proliferate those cells and make sure that you're constantly producing enough to feed your new baby. So there's 5 Ps that can cause a hyperprolactinemia. It can be because you are pregnant and you're preparing for a baby. It can just be physiological levels and you're just producing a bit too much. It can be pharmacological, as we'll talk about in a second with the antipsychotics. It can be a pituitary adenoma. Oh my God, this is so shocking. We've not heard about any pituitary tumours today. Or it can be with PCOS. Exact reasoning, not yet known. People think it's to do with an excess of estrogen. Estrogen. Here we go again with the penguin thing. But PCOS can cause raised levels of prolactin. So look for a galactorrhea, look for menstrual cycle changes, look for hypogonadism, and look for osteoporosis. And then this was just a review of antipsychotics. I thought it would be helpful to pop in. When I was on psychiatry last year, one of the doctors, the registrar, sat me down and taught me through like metabolic side effects. And this was the table I made from it. It's all to do with dopamine blockade, because most of the underpinning mediator of psychosis is your dopamine. So you want to block that. in psychotic patients to basically calm their nervous system back down. But the risk of doing that is dopamine itself is a blockade to metabolites. So growth hormone, less of a problem. However, prolactin, big old problem. So the atypicals were developed because of the extrapyramidal side effects of the typicals, which is your Parkinsonisms and your acute dystonias and everything like your ocular gyric crisis. But they didn't quite manage to fix the dopamine issue because it's the D2 receptors that are the problem. So you still get a fair bit of your metabolic side effects just without your extrapyramidals. So your peens, your dones, and your zols still tend to cause you metabolic problems. But yeah, I thought this would be a good one for people if you want to like review this later on. It's just to think about pituitary tumors and the different ways they can present, because the adenoma can literally be any of the hormones. And then you can think about, okay, I've got a heat intolerance, I've got weight loss, but also I've probably got menstrual cycle changes, and then think of your differentials and then just keep going down like that. Because if you get one, you kind of have to screen for the others. And sometimes I like to leave like an open-ended review exercise in the slides, because it's nice to have a prompt sometimes. You don't have to think about it all for yourself. So visual fields, just in case you've forgotten about why you get the bitemporals, is because you cross over your inputs. And then when your nerves actually cross over through the optic chiasm themselves, and you get the lesion in the sella turcica, it's going to compress precisely on the optic chiasm, which is going to mean that this input from both sides is affected. So your temporals are going to be what goes. And I've just put some colours on the diagram to help you, in case that was confusing. Any questions on AP's H's? Nope, seems like we're all groovy, gang. Okay, because next thing I'm moving on to is pituitary, posterior pituitary even. It's 8:02. I'd ideally wanted to finish at 8:02, but I love a yap. So I'll continue recording this session. Again, if anyone needs to read, please do feedback. And yeah, we'll take a little break now, come back at 5 past, and then I will speed through the rest. But I hope that's okay with everybody. I'm just going to find the feedback form I popped in the chat and then put it. Okay, there you go. That's the feedback form. Oh wait, no, that's the Teams link. I'm done. Oopsie daisies. Okay, this is what I meant to put. That's the feedback form. So if anyone needs to leave, please do the feedback form. And then I'll be back teaching in 2 minutes. Okay, lovely stuff. I've had a munch of a cheese twist. I hope everybody else has had time for snacks. If you have not had time for snacks, remember, I have a phone. I can explain things again. And this is all recorded. So make sure you eat. Make sure you have some kind of hot drink. Because I started late today, so I'm still on caffeine, which is a dangerous game to be playing when I'm trying to restore my sleep cycle. However, here we are. So let's kick off with posterior pituitary, and then we leave these axes behind. Parathyroids, pancreas, bedtime. Oxytocin is quick. Because oxytocin mainly comes in PPH. Oxytocin is important for muscle contraction. It's either breast or uterine. It's also important for things like orgasms, but that doesn't really come up in UKMLA. It can also be important for testosterone levels in the testes, but again, I've not really seen that come up. So if you have increased levels of oxytocin, you can actually end up with a BPH. If you've got low levels as a woman, you're losing your breast milk reflex. But again, I've not really seen these things come up. When you've got low levels, you can also have a diabetes insipidus, but that's more to do with posterior pituitary dysfunction, and we'll talk about ADH soon, but they tend to be concomitant, because just as we had adenoma might cause all of the different hormones to be out of whack, if you've got one not coming out of the posterior from the same mechanism of neurosecretory cells, it's possible the other one won't be coming out either. So that's your oxytocin. We tend to think about oxytocin when people are having a PPH because you've got the 4 T's. You've got tone, trauma, tissue, and thrombin. Atonia of the uterus is the leading cause of postpartum hemorrhage and ongoing hemorrhage. So you give them synthetic oxytocin, causes that contraction of the uterus, clamps it right down, please stop bleeding. So that's one of your first line interventions in a PPH. But other than that, oxytocin is not a big player in the UKMLA. ADH, though, is a funky one in terms of how it comes up. ADH is really important. We talked about it before in terms of the aldosterone escape. But ADH is basically important for controlling how much fluid you pass out and like concentrating your urine in your collecting duct. So ADH is the only thing I'm pretty sure that makes you permeable to water in your collecting duct. If you don't have ADH, you're just going to pee it all out. If you do have ADH, you can bring some of that water back in, concentrate your urine, and decrease how much you're diuresing. So decrease the volume of urine that you're passing, and therefore retain more fluid. So another name for it is vasopressin. It specifically binds V2 receptors and inserts aquaporin channels. If you don't have the ADH, water can't leave the nephron, so it has to stay in the urine and you have to pee it out. So you can either have too much or too little, just as with everything else we've been talking about today. We will start with too much. So if you've got too much anti-wee, you're going to be concentrating your urine far too much and holding on to far too much fluid. You've got lots of water in your system. Before we had too much fluid, we were getting headaches because it's all backlogging to our brain and it's very careful pressures and ventricles and all of that. You get that in SIADH. You get a cerebral edema and you get neurodysfunction because any changes to the flow through your brain, you're going to get neurology. So it tends to come in the form of a neuroendocrine tumor such as SCLC, but you can also get it in a brain injury such as subarachnoid. You can get it with certain infections. You know how we were talking about Neisseria meningitidis before and atypical pneumonias? Strep pneumonia is not really an atypical one, but I don't think it's a coinkydink that those vessels can affect your adrenal glands and your sort of neurological endocrine tissue, and they can affect your pituitary in a similar way with ADH. I think there's probably something in the microbiology of those bacteria that mean that they affect those as well. So just as we had with Waterhouse-Friderichsen syndrome, your Neisseria and your strep pneumoniae, in this case, we've got a meningitis and a pneumonia again. So it can cause syndrome of inappropriate ADH. and you need to fluid restrict them. They're holding on to too much fluid. Don't give them any more fluid. But there's a really counterintuitive correction of sodium that has to go on, because when you have too much sodium, it will appear as sodium is too low because it's dilutional. So you need to be very slow in any kind of correction of sodium and fluid balance. Fluid restrict them, first of all. It's not dissimilar from what you do when you're trying to correct like a liver failure and they've got fluid overload. Just be really careful. And you can use this fancy med as well instead. Now let's tip it the other way. I've not got enough ADH, so I'm just constantly peeing. I can either have this because my ADH is not working in my kidney, or I'm not being given enough ADH from my pituitary. Same as everything before. Is it my fault or is it the pituitaries? Notice how the hypothalamus is sitting pretty. It's like the CEO of a company overseeing the line manager bickering with the receptionist. He's like, this is all me because I'm not paying either of you enough. But they're both getting the blame. Endocrinology is the same as life. The way you do one thing is the way you do everything. So nephrogenic diabetes insipidus, you can perhaps have given that medication you were trying to give to correct the ADH levels before, and you've messed up the ADH system in the nephrons. So it can also be due to medications like lithium. Just as lithium messes up the thyroid, so too does it mess up the kidneys. It can be due to other underlying electrolyte imbalances that just mean that ADH is the least of your worries right now. It can also be a cranial cause. So have you noticed how our favourite infiltrators are back? Sarcoidosis and hemochromatosis. They presented before in the thyroid with infiltrative pathologies of the thyroid. They are now back to plague us through cranial diabetes insipidus because they're infiltrating the pituitary, causing it to malfunction, and you've not got enough ADH anymore. So honestly, in endocrinology, sarcoidosis, why do we put it in respiratory anymore? It can just be everywhere. They should have a separate specialty called sarcoid. Deprive them of water. So essentially, you want to assess if it's truly diabetes insipidus or not. So you want to basically leave them without water for a certain amount of time, because remember, ADH is anti-wee. It wants to make you hold on to your fluid and only get rid of a tiny bit. If you deprive them of water, they shouldn't be peeing out a lot. But if they continue to, that probably means your collecting duct is letting out far more than it's meant to be. So you can measure blood levels of ADH during that time if you wish. In the water deprivation test, look for your result of that. Look if they're still having similar urine output, if their weight's going down, because remember, you've got the 1-to-1 ratio for how much water weighs. I think it's 1 ml to a gram or something. If you think it's cranial, so you think you're not producing enough ADH, try giving them some and seeing if that changes things. But if it's nephrogenic, you need to think about, okay, I need to limit my salts because it's throwing off my water balances. And you can also use thiazide diuretics. We haven't really talked about thiazide diuretics today, but I will find something on their effects because they also cause a hypercalcemia and so on and so forth. They have a very specific action. I'm pretty sure it's sodium, potassium chloride, co-transporters and stuff and messing up gradients, but it works with nephrogenic DI. And that's your posterior pituitary hormones. I said it would be quick or pickle, and it was. So just testing some knowledge from the adrenals. We talked about this before, but just seeing if it's being taught well. Yeah, legends. Yes, it is the plasma aldosterone renin ratio. And my goodness, you can't see that once I've highlighted it, can you? So it was just about discriminating, like we were talking about before, that you want to basically prove that renin is not at fault, it's not being overproduced by the kidneys, and instead aldosterone is just being produced by somebody else. We're not querying bilateral adrenal hyperplasia, so we don't need to do adrenal venous sampling. We think it's a Conn syndrome, which again, your little adenoma. CT abdo is not really as effective as a renin-aldosterone, and a dexamethasone suppression test that was looking more at our adrenals in general and their response in cortisol instead of your plasma aldosterone. So yeah, well, how are we doing for the UKMLA? Again, we've knocked off even more problems because when it comes to prolactin, you can get men with erectile dysfunction, you can get a galactorrhea, you can get some changes with some sort of like gynecomastia type changes, nipple discharges, pubertal changes. So in terms of how much we just knocked off with all that brain stuff, I know it might have seemed a bit silly, but we've kind of covered every presentation in the UKMLA now. I will continue to talk about diabetes and the diabetic emergencies, but we've done a damn good job. So thank you for sticking with me. All right, parathyroids, look how cute they are with their little cheeks. The ever neglected, cute little gland that gets damaged in surgery and gets ignored when endocrinology is taught, including by me at times. So just to recap what the parathyroids do, it's released from chief cells. You have superior and inferior parathyroids. And if your calcium is low or your phosphate is high, PTH release is stimulated. Its role is to increase the resorption of bone, but also increase the renal reabsorption of calcium and increase the synthesis of active vitamin D, which then helps you absorb more calcium through your GI tract. However, if you get that negative feedback and your calcium becomes raised again, suppresses your PTH production. Ditto, if you have lots of active vitamin D being produced, you're not going to have as much PTH. This is really important in terms of interpretation of bone profiles. PTH is a major player in bone profiles. So in your bone profiles, you tend to get your calcium, your phosphate. You have to request a separate vitamin D, but you also look at your ALP, because if you've got like an isolated raise in ALP, you're thinking more of like a Paget's disease of bone. And we'll go through with the parathyroid how it presents in terms of your calcium and your phosphate and your vitamin D. So, disruptions in calcium. I think we all know about hypercalcemia at this point. Bones, stones, groans, and psychic moans. Bones, you get bony pain because you're basically getting excess of calcium and you're prone to like bone damage. Stones, you get renal stones. Groans, you get tummy pain, nausea, vomiting, possible bowel changes. Psychic moans, you get memory problems, difficulty concentrating, your mood sucks, and you're generally a bit all over the place. And then, of course, you get that possible shortening of your QT interval on an ECG. So, 90% of hypercalcemia is primary hyperparathyroidism. And although I didn't put in my nice full list of hypercalcemia of malignancy, which goes into ectopic PTH production versus eponymous vitamin D production, this is the main causes of hypercalcemia of malignancy. So squamous cell carcinoma loves to produce calcium, and it was an SBAR we got a few years ago. My God, it was last year. I'm talking like I've been here for many moons. No, it was last year. We had a hypercalcemia of malignancy and we needed to handle the patient in one of our exams, and it was like rehydrating them and then possibly putting them on some bisphosphonates. But you can also get metastatic cancers where they basically cause the bone to be damaged and release lots of calcium, because when you stimulate the bones, they release their calcium and phosphate stores. They're a really good buffer system for calcium in the serum. And then, of course, you get your granulomatous diseases, such as, you guessed it, sarcoidosis. Sarcoid is our best friend. And then acromegaly as well, with your IGF-1. It also has an effect on bones, so that's going to affect your calcium. Other one, though, hypocalcemia, I always forget about. So you've got your Schwarzschild sign and your Trousseau sign. So you look for a prolonged QT interval, which obviously puts you at risk of your torsade de pointes, which is your sort of like rotation around the baseline on your ECG. If your parathyroid's low, that means you're not going to produce the nice PTH, you're not going to get more from your kidneys, you're not going to get more from your GI tract, you're not going to release more from your bones. If you've not got vitamin D, you lose that ability to take it up from your GI tract. Chronic kidney disease, you can't produce your active form of vitamin D anymore, or your inactive precursor to active vitamin D. The liver's the one that does the final conversion. And then you get low levels of magnesium as well, because there's a very tight interplay between magnesium and calcium. We sort of alluded to it earlier when talking about the kidneys. Give them some gluconate and treat any underlying cause. And then this is a nice summary table in terms of hyperparathyroidism. I'll give you guys a second to read it and then just ask any questions. Oh, yeah, of course, Janella. This is separate. Adrenal venous sampling was when you wanted to query between if the aldosterone was due to Conn's syndrome. So Conn's syndrome is when you've got the adenoma of the zona glomerulosa, where you're just making aldosterone. Renin's got nothing to do with it. So you calculate the ratio. Adrenal venous sampling was when you thought it might be bilateral adrenal hyperplasia. And I've not seen it come up as a situation. I don't know if you get like a funky CT and then you do adrenal venous sampling. But
yeah, I think, Charlotte, I think you're right. So you do a CT for everyone to make sure it's either bilateral hyperplasia or cons. And then you do the venous sampling if your CT is a bit weird to basically distinguish.
Amazing. Honestly, you're like the oracle. I love having you on these calls because it's like anything I can't just close my little Teams call and look up. You already know. You're brilliant.
You know all the things we don't know.
That's why we're such a good team, guys. Collaboration always.
You know what I found really interesting is I don't know if you have a slide on hypoparathyroidism later on.
I don't think I do.
So what I found really interesting based on a question I read is that the biochemical pattern seen in hypoparathyroidism is, although obviously you develop hypocalcemia, your ALP levels is normal because the PTH is actually what drives bone turnover. And I found some questions in like old final like question books basically asking in which condition the ALP will stay normal. And the answer was always hypoparathyroidism, which I don't know, because it messes up your bones. You'd think that, you know, the ALP would get messed up, but it doesn't because there's nothing to actually drive the resorption of the bone.
Oh my gosh, that's so interesting.
So your parathyroid basically is low, so your calcium goes up, and you would expect that your bones would get, you know, broken down, but there's nothing to actually drive that. So your ALP is normal.
That's so cool. Thank you so much for sharing that, because I would never have known that otherwise. Because you just get all these funky ALP changes, and I never really deep it personally. But
yeah, just wanted to mention it was really interesting.
Yeah, that's so cool. Another one I popped in here was about the long-standing CKD because it can mimic. It starts off as like a secondary hyperparathyroidism, and then later on, because you've had such chronic stimulation of PTH in the parathyroids, they start producing excess sort of by themselves. So you end up with it's actually a tertiary picture. So they'll have low to normal vitamin D, but it's due to their long-standing chronic kidney disease because of its key role in vitamin D synthesis. And I just found that a tricky one to wrap my head around when I did it. So pop that in here too.
No, they're so cool. Thank you.
You're so welcome. So love having you here. Oh yeah, we do have a slide on hypothyroidism. Funny. This is just how you correct it though. So you've got primary usually because thyroid surgery, parathyroids are just behind and you nick them and you damage them. Low calcium, high phosphate. But we've not put anything on ALP in here. So we've got the lovely bit of information now from Anastasia about ALP remaining normal in hypoparathyroidism, which is super cool. So, moving swiftly on, which of the following is a sign seen in acromegaly? Yeah, Brill, acanthosis nigricans. So it's seen in patients with any kind of obesity, insulin resistance, and if you've got acromegaly, remember it's that disruption of the insulin growth hormone axis that they usually work quite nicely together, and that's all coming back to the glucose and how it should suppress growth hormone. If you've got acromegaly, you're going to get patterns of a bit similar to insulin resistance, so you get darkening of the skin. Okay, and that is that. And now we are on to our final stretch, which is the endocrine pancreas. I've gone on longer than I intended to, but I'm hoping it's been useful for everyone. And you've gone through all of endocrinology in one night, so pat yourself on the back and get a good night's sleep. All right, so endocrine function of the pancreas is very specific to the functions of the islets because you've got the HPB, the hepatobiliary system, which is more of a like gen surge area. And then you've got your exocrine pancreas, which is much more of a gastroenterology type thing, and it's very careful stimuli from your chyme that comes out of your stomach, which then stimulates different hormone production and such. So endocrine function is about what's getting secreted directly into the bloodstream. So insulin is produced by beta cells. Rising glucose levels causes insulin to be produced. However, if you don't want any more insulin, somatostatin can come in and tell it to shut up. And your sympathetic nerves, your fight or flight, can say, Ayo, please don't lower my glucose right now. I really need that stuff free for my cells. But then similarly, in those stress situations, cortisol can also tell insulin to quiet down. Epinephrine itself from the medulla of the adrenals can tell it to quiet down, and then growth hormone we've been yabbing about the whole growth hormone insulin axis for a little while, and how insulin-like growth factor comes together with growth hormone to cause acromegaly. So all the insulin and growth hormone stuff, glucose should tell growth hormone to chill, growth hormone can tell insulin to chill. Growth hormone and glucose, best buddies. Alrighty, so in terms of the diagnostic thresholds of diabetes, choosing medications, I genuinely think that's one I could have made a slide on, but timings-wise, I thought the more critical things was the fact that we had a mock exam as a university-wide exam, and it was a patient with type 2 diabetes mellitus, and I believe one of the examiners said she examined 20 people and nobody asked for ketones. So the acute presentations of diabetes mellitus, if you get someone who's hyperglycemic, ask for their ketones. Just because they're type 2 doesn't mean that they can't get ketoacidosis. You can even get euglycemic ketoacidosis. On a history of diabetes, check their ketones. Even if you're on the ward and someone spikes a glucose, I can't remember the exact threshold, nurses are told to go and get the ketone meter because you need to figure out the driver, because you can start getting peripheral production of ketones as a surrogate for glucose. So on your DKA, you do your A to E assessment. Tends to be kids that often come in with type 1 as first DKA because they're just more thirsty, they're peeing more, and not everybody knows the signs and symptoms of diabetes. So you make sure that you fulfill the diabetic part, a glucose of more than 11, a keto part, which is ketones of more than 3, and they need to be acidotic, which is a pH of less than 7.3. You need to fluid replace, and you need to get insulin going. You start with fluids first, then you can start introducing glucose in your subsequent bags once you've started your insulin. So start with plain saline, start a fixed rate infusion at 0.1 units per kilo per hour. Then you can start worrying about your tipping back and forth balance. Fixed rate infusion. Think about your VTE prophylaxis, like we said before. When blood gets disrupted, it loves to clot. So just have a think about that if you're admitting somebody. And then your HHS. Type 2 diabetics, typically, you want to look at your serum osmolality. You want to look at a plasma glucose of more than 33 because it's an insulin insensitivity, a resistance in type 2 diabetics. Type 1s, they just don't have any. So they're finding new mechanisms through which they can get rid of their glucose in the form of ketones. Again, you need that fluid resus. Careful bringing down of those sodium levels because we know about that careful SGLT2 channel in the kidneys. So if the BMs start to improve, you can think about starting insulin, but otherwise it's all about IV fluid resus in both presentations. Both could come up as an A2E at Manchester, both could come up as a complication question for diabetes. Just going to check for any questions. No, good. So yeah, imagine it's an adult and they're suddenly going to the toilet more, they're more tired, they're thirsty and they're thinner. They'll come to the GP and it's due to immune system overactivity. Try not to say when you're explaining to patients that the body is attacking itself. There's been studies to show that patients really don't respond well to that. It feels like a battle they're losing. Same comes for cancer for most explanations. So just try and avoid an autoimmunity. I like to say your body's being overprotective because it's more of a like softened approach instead of like a really aggressive, you're being attacked, because you're literally telling them this is going to happen their whole life and they're going to be like, what if they get new recruits? What if they get new troops? What if they get better weapons? So try and make it a bit less of like a you're going to war and more of a your body's just doing too much. It's a nicer thing to hear, an easier pill to swallow. Because then in terms of diabetes long term, we know about you can give oral hypoglycemics, you can give insulin, there's different things you can give, but the main thing that community practitioners are responsible for is initiating those meds and following up for complications. So on the one hand, you have microvascular complications, which is where you get excess glucose and damage to small vessels. Then you get macrovascular complications. So starting off with peripheral neuropathy, just reviewing your diabetic foot exam. So you want to look for fine damage. You get your little capillary that runs through your nerve and it's going to start the furthest away from your hefty blood supply. So it's going to start from the toes and work its way upwards. So you need to look at the feet, inspect for any changes to the skin, and that doesn't mean look at it from the end of the bed. It means going between every toe, looking at the sole of the foot, looking where their foot is in their bed, particularly for patients who don't get out of bed. The ones we saw in A&E, I don't think their feet were ever being picked up, and they get really nasty changes and ulceration under the bottom because they've essentially just got necrosis and all sorts of nasty stuff going on under there. So look for Charcot joints. Look for any muscular wasting, do a vascular exam, make sure they've not got any signs of critical limb ischemia, because that should be on your differential list, any sort of like paresthesia changes in a person who's got other risk factors similar to diabetes, but more of like a cardiovascular risk factor profile. Could they have critical limb ischemia if they've got like claudication, acute tissue loss, etc., etc. Just keep it in your differentials. Worst thing you can do is be wrong and have checked for it. So keep an eye on if they're well perfused, CRT, consider a Doppler if you can't feel their pulses, do a neuro exam, use a monofilament and you do vibration sense as well, and then you can follow that up with the precise neurotip and reflex assessment. So this is just your monofilament, and these are the different sites you check. Big toe, along the metatarsals, and then the fainter ones are the extra sites you can check. Then you've got your fundoscopy. So this is another one that can come up. And remember, when you're looking at the fundus, you need to have a systematic approach. It's very unlikely you'll be able to look in someone's eyes, as their pupils usually are, especially A&E. Our lights are quite jarring. So you need to dilate them in order to be able to see. check first for the red reflex. If they've got no red reflex, you can't do fundoscopy because it might suggest they've got like a cataract or something that's in the way between you and the retina. If you have got a red reflex, continue to pursue further. You need to kind of follow a vessel along. I actually managed to do this in GP and I felt like the king of the world, and then I went to do it with such confidence on the next eye. Couldn't see diddly. So just if you find a vessel, follow it and make your way to the optic disc. Then look for the cup, the contour, the colour. And you can then, from there, it's like your roundabout and you can take all your different exits. And then you can do a U-turn, come back and keep looking through all of them. Because essentially you're looking for any changes across any of those sort of vascular distributions, looking around them. And we're looking for things like, have they got any teeny tiny new little blood vessels, suggesting a proliferative retinopathy? Or have they got little aneurysms developing, tiny hemorrhages? Have they got hard exudates in the back, suggesting they've got little areas where they've not been perfused effectively? So your normal retina's on your right, and I just thought this was a really nice comparative image. And you can also get pretty sure it's called Adam Neal's booklet of diabetic retinopathy type changes that can come up in OSCEs, but I think just doing the ophthalmology sections gives you lots more pictures to look through, because I think pictures are hard actually to get like all of them, all the different changes, because to me, non-proliferative and proliferative look dead similar. It's more you just get more red on the proliferative one. So if it's proliferative, you can basically stop the proliferation, get rid of the small vessels, either coagulate them with a laser or inject them with a substance that stops them being able to grow. If those little vessels, though, cause a hemorrhage and that build-up causes pulling on your retina and basically brings it forward, then you need to do a vitrectomy. If it's non-proliferative, you just need to tighten up your glycemic control and hand them over to ophthalmology for help. Okay. In terms of your diagnostic criteria for diabetes, those ones were imagine someone had poor control, particularly with chronic conditions. It's really hard to motivate people if they feel like they can't have a success story to like advocate for their health and take initiative and look after themselves. So imagine those were their first presentations and now you need an HbA1c. If it's 42 to 47, they're pre-diabetes. So sod's law that they've got all of those already. It wouldn't be the case. It would tend to be, it's much more like 55 or something ridiculous. What was the highest I saw? I'm pretty sure I've seen some 70s. Like, it was really bad, particularly in areas of the country of low literacy rates and low access to education. People just aren't motivated to take care of their health, which is a really sad thing to see. So targets, if they're a new diabetic, try and bring them to a 48, so that threshold. If they're already on a diabetic drug, try and bring them to a 53. I don't know why that criteria has just snuck its way in there. I'm pretty sure that's me playing around with slides because I accidentally duplicated some and deleted others earlier and I tried to put them back together normally. Alas, information. Nephropathy, that's one. Diabetes loves to cause all sorts of renal damage. So just look for the progression in the how porous your kidneys are. So you start off with like a little bit of albumin and then a lot of albumin and then just any protein. And then you finally see your eGFR start dropping off and being like, oh, panic. So that's your nephropathy. U&Es, have a look at those for any derangement. This is your thresholds for sort of the risk associated with CKDs. You do your ACR and your GFR. ACE inhibitors, we like to use ACE inhibitors, particularly in patients who are hypertensive and diabetic, because it has that sort of dual effect of being renoprotective as well. So that's how I've been remembering the hypertensive guidelines. If they're diabetic, give them an ACE inhibitor. SGLT2s are also quite good for that as well, because they're quite specific to the kidneys. Okay, complication spotter, 2 ECGs. If you came last time, you're going to know the answer to this. If you didn't come last time, it's all new. Oh my God. A HbA1c of over 100 in ICU. Okay, moving swiftly on. So in the top one, all you have is a sinus tachycardia with evidence of a right bundle branch block. And in the other, you have evidence of an inferior STEMI. So inferior means you're looking in your inferior territories. So you're looking for leads 2, 3 in AVF. And then you're also going to get some reciprocal changes in AVL. I'll put up an ECG thing on territories in a bit. But in essence, that can be a macrovascular complication of diabetes. Another macrovascular complication is a possible stroke. Now, I put up these two horrible CTs last time, so if people want to have another go at which one's which one's the stroke. Because on the left, you've got a infarct of the posterior cerebral artery, whereas on the right, you've got a meningioma. So I took these from Radiopedia. Yeah, first one. So it's this sort of, I think you call it hyperdense region when it's darker, and then meningioma over here. This is more of a tissue swelling. So it comes out as white. If anyone's good with MRIs and can explain why that is, please do, by the way. And then this is just a review of your insulin prescribing, because they have different durations of action. This was particularly useful for me when I was doing my MLA. So it's Act Rapid, the one that you love to use in your DKA fixed rate insulin infusion. And then your other ones, it was during surgery, I think you hold their short acting, keep their long acting going as usual when you take over their glycemic control. So yeah, any Novarapids like insulin aspart, stuff like that, stop that and continue the glargines and detamirs. And then I finally made the diabetic drug toolkit. So particularly look at metformin, lactic acidosis, and SGLT2's euglycemic ketoacidosis. I feel like those are heavy hitters. But I made this with help of the lovely Zara Lynn, who is an F1 who wants to be an endocrinologist. So she helped me make this. It's much more simple than what I ever would have made. So thank you very much, Zara. And I hope it's helpful to you guys as well. You can have this. It is my gift to you. And then I kept mentioning about secondary diabetes. So it's not always autoimmune disease or insulin insensitivity. It can be completely different issues. So you're going to see, shock of all shocks, hemochromatosis in this list? That's not come up at all. And you know, all the other endocrine problems, they can also cause secondary diabetes. And steroids. Oh my God, steroids can cause secondary diabetes. It gets a bit repetitive after a while. However, hopefully this whole session has made it make more sense why these different things happen. So this is just a summary of diabetes and pregnancy, because you've got gestational diabetes, but then you've got any pre-existent diabetes. So the gestational, you've got your 5, 6, 7, 8. If it's greater than or equal to 5.6, just chilling, versus 2 hours after glucose tolerance test more than 7.8. You can diagnose gestational diabetes, but if it's greater than 7 straight off, as they're fasting, you worry you need to start insulin pretty quick. Whereas if it's less, you can kind of play around with diet first. If that helps, cool. If not, get them on some metformin. Because the other ladies with type 1 and type 2, there's lots of risks you should be counselling on to them and to their baby before conception, and the importance of getting tight glycemic control. If they're type 2, once they do get pregnant, you need to stop the other oral hypoglycemics that are not metformin or insulin, because they are teratogenic and they are harmful to baby. So I put one of the associations as TGA. I should have put that down as risks to baby, but I've put it in the other list. So just be aware that women need to be on higher folic acid, if they've got diabetes. They're at greater risk of preeclampsia and therefore eclampsia. What comes before that? Gestational hypertension, and they're at risk of perineal tears from their macrosomic baby. So you do a cranial to abdominal ratio, I'm pretty sure, to look for macrosomia. It just shows that you've got big baby. That's in part of your scanning. And then these are our last questions. Da, 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 da. Okay, we've got D, D, B. It is ongoing parathyroid hyperplasia. So this is what I was talking about before, because it's about that chronic stimulation of the parathyroids due to chronic kidney disease. They're constantly saying, Ayo, please, I need more PTH. We've not got enough calcium because you've got no active vitamin D. So your calcium levels are really low. So your PTH is like, I'm trying. And then it basically goes hyperplastic and you keep producing loads unnecessarily. And it's a tertiary picture because it's not the fault of the parathyroid glands. It's the kidneys. Okay, next one, which are seen in diabetic retinopathy. See, amazing. Yep, spot on. And then which puts a patient at risk of euglycemic ketoacidosis, to really drill the point home for anyone doing a A2E or prioritization station, including a type 2 diabetic. And to remind you of the name. D, lovely stuff. Yeah, SGLT2 inhibitors. Brilliant. So thank you so much, guys. I got feedback last time I did this session. I kept saying, oh, guys, we can stop here, we can stop there. And people said they would have liked if I just kept going. So I kept going today. And it went on for a long time. But I really hope you guys got some benefit from it. And that it helps you off your MLA. And you do smashingly well. And do really, really well in your OSCEs as well. So yeah, thanks so much all for coming. I'll put the feedback form in the chat. And then we've got renal and hematology teaching, not from me next week, but I love teaching. I really appreciate you guys always showing up to support me because it makes it so much more fun when I've got like little responses coming in the chat and stuff. So thanks, guys. Da, 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 da.
Thanks,
You're
Charlotte.
welcome. You're welcome. Thank you. Just gonna. Yeah, good luck, everybody.